Good morning and good afternoon, everyone. My name is Anjay Rastogi, and I would like to welcome you on behalf of UCLA Core Kidney Program and UCLA Health to our symposium on kidney stones. We have an amazing guest faculty today, and I truly hope you enjoy it and learn from it, and it hopefully will change your practice as well. But before we get into the kidney symposium or kidney stone symposium, I do want to spend a couple of seconds on the current time, or times actually. And the term that has been used quite often is unprecedented. And it has, this year has been quite unprecedented, to say the least, with the pandemic. But, and the winters is going to be tough, but I am very positive that after that, things will get better. And by summer, we'll have some normalcy. But these are tough times, and I want to thank all the audience today who are at the front line fighting the pandemic, fighting kidney disease, and providing care to our most vulnerable patient population. Our kidney patients, whether diabetes is the cause or they're on dialysis or transplanted, the chance of them getting complications from the COVID is pretty high. So thank you very much, and please stay safe and take care of yourself as well. We need you more than ever. So thank you once again. Now, the topic today is the kidney stone and how we manage it. But before we get into the burden of kidney stone disease, let's talk about kidney disease by itself and the burden. So if you look at the stats, 1 in 7 adults in the US have some form of kidney disease. 1 in 3 are at risk. And there's significant mortality, morbidity, and financial cost that is associated with kidney disease. And unfortunately, we don't talk about that much. You can see this green ribbon over here, and you'll be seeing this on all our faculty as well. And this is something that we started at UCLA under the Core Kidney Program about increasing kidney disease awareness. When we see pink ribbon, we don't have to be told it's breast cancer. But when we see a green ribbon, a lot of people don't know what a green ribbon. I didn't know. One of my patients actually told me about that. The 5-year mortality in kidney disease is higher than some of the more common cancers, but we don't talk about kidney disease. And one of the messages I hope you take from today is kidney disease is important. And if we are going to improve outcomes, we really have to focus on early diagnosis and treatment. So last year in 2019, this is obviously before the pandemic, there was something called Advancing American Kidney Health Initiative that was passed, enacted, and some of the key focuses of this initiative were to increase home dialysis penetration rate. And now in the pandemic, there is no better place than to be at home. But there is a big focus because of patient outcomes, and more than that, is to increase the number of patients who, if they're on dialysis, they are on home dialysis. UCLA has been at the forefront. 50% of our dialysis population is on home. And this is compared to 10% on national. So we are way above and ahead. And retention is something that we really focus on. The other big focus is transplantation. That is, in majority of patients, still the best modality, and we push it. We push it quite hard, so hard that is preemptive transplant. There is a major focus at UCLA on kidney transplantation and living donor, especially if we can get it preemptive. So we have been doing that, but there is an organ shortage. And today we will be talking about liver transplantation. Dr. Lieske will be doing that in his discussion, and organ shortage. And it was kind of interesting. I was watching on Netflix a show called House of Cards, and there was discussion about liver transplant for our president, and not that it has anything to do with our presentation today, but it really back to the forefront that what a life-saving process it is, and those organs should be allocated to the people in most need. And if we can decrease the need for liver transplantation or kidney transplantation, that will be quite amazing, and that is our goal. And that brings us to my third point that was from the Kidney Health Initiative, is slowing down the progression of kidney disease. Now, for slowing down progression, there's some key aspects of that. Now, the first and the foremost is early diagnosis and correct diagnosis.
Thank you.
I always say garbage in, garbage out. If you do make the wrong diagnosis, you've got the wrong treatment that can be actually causing harm. And after the right diagnosis, it's early intervention and hopefully prevention, primary prevention. So those are the big focuses. And this year, we had a lot of good data coming out on a class of drugs called SGLT2 inhibitors. And after a long time, we had a class of drug that slows down progression of kidney disease. And actually, for the SGLT2, this year, we got even more data that it's not just for diabetic patients, but non-diabetic CKD patients also can get benefit from this class of drugs. So this is all very exciting. So there is a lot to look forward to, and science is going to lead the way. It always has, and it will in the future as well. But so why am I talking about all this, and how is it relevant? So when we were initially planning this symposium, and by the way, I want to thank all my guest faculty, and I do want to say, with no pun intended, the guest faculty that you'll have today are rock stars, in more than one way, and I'll be introducing them. But we put this program together in 6 weeks or less. Corey from our CME office, Christina, and my whole team, got together, Scott, and we all came together to put this program together in 6 weeks. So this was because we thought it was important. And one of the focuses initially when we were thinking about this program was genetics. Now, we at UCLA in the core kidney program have a big focus on genetic causes of kidney disease. Going back to 10 years, we started the ADP-Kidney program. Now we have ADP-Kidney programs almost everywhere, but at that time, there were very few. I mean, Dr. Lieske, who's one of our key guest faculties at Mayo Clinic, Dr. Torres had a PKD program, and there were a few others. But we started that, and here at UCLA, and now we then added Fabry's, then we added LPORs, then we had ApoL1 for living kidney donation. The significance to once again minimizing the risk to our potential living donors, and then now primary hyperoxaluria. So for all this, we started and launched just recently genetics and kidney disease at UCLA, and we are very hopeful that this will change the way we practice medicine in the near future. And we are partnering up with our genetics program at UCLA. Dr. Bianca Russell, that you'll be hearing very soon, is our partner, and she is providing us the support from the genetics program. So genetics is very important, but it's not just for diagnostics. Diagnostics are very important, and we have a lot of exhibitors. Please do visit their booths. You'll get quite a bit of very useful information. And one of our exhibitors and sponsors is Natera, and they have this arena site. They have a whole panel of about 400 genes that are tested. So the diagnostics are quite important. And there are a lot of other, you can talk to Dr. Lieske. They have 105 genes that they test for kidney stones. And there's a whole bunch of other panels as well. But please get yourself used to testing more. It's not like even 5 years ago when it was difficult to get the testing, were very expensive, took a very long time. So we have come a long way in diagnostics. But also let's talk about therapeutics, modulating gene expression in an ethical, moral, and legal way, and medically safe way. There was a drug just recently approved for primary hyperoxaluria. And my background is also pharmacology. My PhD was actually in pharmacology. And when we look at therapeutics, it's really fascinates me how we are advancing the therapeutic aspect. So modulation of gene expression, gene silencing, use of small interfering RNA, as a therapeutic approach. And Dr. Lieske will be going over that in a lot more detail. But this is all great. I know this year has been quite rough and tough, but we'll get over that. And there's a lot of things to look forward to. But genetics is something that we will be focusing on in the next decade. And that is, along with immunology, in my opinion, will really be the front and center of kidney disease management in the future. And this is, is for generations. It is for family planning, family counseling. There's a lot of stuff that goes into genetics, and so it's really a very truly comprehensive approach. So that was a bit of my introduction. Now, like I said, we have a very amazing program for you. But before we get into the symposium itself, the presentations and the discussion, we will be giving a bit of an overview of UCLA Health and the kidney stone program, what we have done, and working as a team, the nephrologists, the urologists, the geneticists, and also diet and nutrition, the diagnostic part of that as well. So with that, I am going to hand over to Dr. Dunn is going to kick off this, and then we'll have our key faculty members and members of the kidney stone program at UCLA. I hope you enjoy them. Thank you.
Thank you for having me here today. My name is Dr. Matthew Dunn, and I'm the Director of Endourology and Stone Disease here within the Department of Urology as part of the David School of Medicine. For those of you who practice medicine in Southern California, I wanted to give you an overview of the services we offer with the hope that if you have patients that develop kidney stone disease, it might be something that they would benefit from. This stone program is relatively new, about 3 years old, which is comprised of myself and my colleague, Dr. Kimura Scotland. And we put a lot of emphasis in diagnosis and management of stones. And specifically when it comes to diagnosis, we're working closely with the Department of Radiology, coming up with safe options for imaging patients with kidney stone disease. As you know, with kidney stone disease, there is the tendency to over-image a lot of patients, exposing them to unnecessary amounts of radiation. So in working with the Department of Radiology, we're looking at ultra-low dose CT scans for accurate identification of kidney stones. We also have 2 emergency rooms which allow us to see patients on the front lines who are suffering from kidney stone disease and try to quickly get them along pathways that allow them to be managed. Our management runs the gamut from observation to the most maximum surgical options. When it comes to observation, a majority of patients will actually pass kidney stones by themselves. The issue is trying to identify those patients who will pass a stone by themselves or those who actually require some type of surgical management. So making the diagnosis with safe imaging is the first step, and then identifying the stone, the site of the stone, and the condition of the patient is the next step that leads us to management. For those patients who actually pass their stones, medical management is still important to prevent a future stone episode. And this is where we work very closely with our colleagues within the Department of Nephrology in having them deal with medical management and the proper medical workup. Regarding surgical options, we offer options that range from the least invasive to the most invasive. I would say the least invasive option that we offer is shockwave lithotripsy, which is still being done in most cities across the country, although not as common nowadays as it was, say, a decade ago. But still, there are numerous patients who are good candidates for such an option, and we still offer that. I would say the majority of our patients who require surgical interventions probably undergo ureteroscopy, either in the form of flexible ureteroscopy or semi-rigid ureteroscopy. The next option we offer, and we actually focus a lot on, is the percutaneous management for complex and large kidney stones. And this can run the gamut from small little incisions where we use microscopic instruments to a more standard percutaneous approach where we actually make a 1 centimeter incision in the skin, put our scopes in, and use either ultrasonic energy or laser energy to break up and remove the stone. I would say at UCLA, we're used to dealing with a lot of complicated patients with complex anatomy and complex clinical situations. So those are the cases that we actually relish because they take a lot of work, a lot of effort, but a lot of satisfaction when they're adequately treated. Once patients are treated surgically, They are definitely followed with regular imaging to make sure that the kidneys and the urinary tracts have healed, have gone back to their normal configuration, and that we monitor for recurrence. I mean, obviously, the statistics are staggering that almost 10% of our population will get a stone at some point in time. So we take the diagnosis and management and follow-up very seriously. Also, we take prevention very seriously as well, which is why we also utilize the assistance of our nephrology colleagues to help with that as well. Here at UCLA, as part of academic medicine, we're on the forefront of research as well and trying to identify risk factors, risk stratifications, and also new techniques and new technologies to improve the management of kidney stone disease. And that is being headed by my colleague, Dr. Kimora Scotland. And I'll let her give you an overview of the research and the work that she is working on as well.
Thank you for having me here today. My name is Kimora Scotland, and I am a urologist at the Department of Urology here at UCLA. I'm also the Associate Director of the Kidney Stone Center. Here at the Kidney Stone Center, we believe in the importance of ongoing research, both at the laboratory science level and clinically. There's exciting work going on in the clinic aimed at improving life for kidney stone formers. Meaningful understanding of kidney stone disease will require real collaborations between nephrology as well as dietary and nutritional specialists and the urology team. At the Kidney Stone Center, we work with individuals in all of these divisions to enhance the care of our kidney stone patients. My colleague, Dr. Dunn, will have spoken to you about our clinical work, and I just wanted to give you a sense of some of the research that we're doing here. A recent initiative with the Division of Clinical Nutrition and the dietitians here at UCLA resulted in patient literature for kidney stone prevention. As we know, one of the challenges that patients face is figuring out which foods they should and should not be eating. And so we plan to continue these collaborations for one reason only, to help patients develop an appropriate diet. But really, once we did this, it became very clear to us that this is information that's not available to patients. And so some of our research projects are very much going to be focused in future on understanding the barriers to dietary changes for patients with kidney stone disease. Several of our clinical research projects in the area of nephrolithiasis prevention, particularly as it relates to patient efforts, as part of a multi-institutional group spearheaded at UCLA, we recently completed a study looking at alternatives to potassium citrate for alkalization. This study will be published in 2021, and we hope that it will prove useful to urologists and nephrologists alike. Our patient-centered clinical projects are focused on every aspect of the patient experience. And we're trying to better understand how it is that patients engage with all the available information on kidney stone disease. One of our major initiatives will tackle the idea of shared decision-making. And in this particular project, we're working on developing patient decision aids for management of their kidney stones. And our aim in that project is to provide easily accessible, easy to understand information on disease to our patients. Our studies will investigate whether current techniques are best suited to achieve this goal, or whether there are better, more easily accepted techniques for patients. Along with the nephrologists at the core kidney program at UCLA, we're working on projects investigating the genetics underlying kidney stone formation. And as you will hear later today from some of our colleagues, the genetic associations of kidney stones are only beginning to be understood. Finally, our basic science work zeroes in on two main areas. The first is a comprehensive investigation of kidney stone pathogenesis and its association, particularly with infection. Our second focus is on understanding renal colic, in particular the mechanisms underlying this phenomenon. And this is all in an effort to develop successful therapeutics addressing the pain that patients experience. We're committed to this multi-pronged efforts at combating kidney stones and helping kidney stone patients to navigate their disease. We think that this should all be through research efforts and our patient care initiatives. And so we look forward to presenting our work in the future and welcome collaborations with like-minded physicians. Thank you for listening.
Thank you for having me. My name is Dr. Ray Gashtasip. I'm one of UCLA nephrology faculties and the new medical director of the stone program at UCLA. I'm also honored to be part of the UCLA core kidney program that focuses on excellence and research in nephrology field. It is also a great honor for me to be a small part of this great symposium. We're going to focus on different types of kidney stones, diagnosis, workups, and their management. Also, genetic diseases in nephrology, particularly in kidney stone, will be discussed today. And we'll talk about a novel treatment that recently became available. We will have world-renowned experts in genetic, nephrology, and urology field here today. As you may know, kidney stones are very common. 1 in 10 will likely experience kidney stones in their lifetime. Most of these stones can be prevented by dietary changes, but some of these stones are related to genetic causes, and early diagnosis and early treatment is very important for kidney health of these patients. Great news is that now we have a new novel medication recently got approved by FDA for treatment of primary hyperoxaluria. I want to thank chair of this symposium and director of the Kidney Core program at UCLA, Dr. Anjay Rastogi, for having me today as a small part of this great symposium. Also, I want to thank you for attending this symposium, and I hope you will enjoy and have a nice day. Thank you.
Thank you, Dr. Rastogi, for the kind introduction and the opportunity to introduce myself today. My name is Dr. Bianca Russell, and I'm a clinical geneticist here at UCLA. Over the past 2 years, I have worked closely with the core kidney team to provide care and genetic evaluations for patients with renal disease. Some of these conditions include renal stones, focal segmental glomerular sclerosis, Alport syndrome, polycystic kidney disease, and Fabry disease. One of the first steps in being able to improve the care we provide to patients with kidney disorders is to understand the underlying pathogen or why a condition developed, which is where genetics really comes into play. If we are able to find the genetic cause for someone's symptoms, that can be a powerful tool for developing targeted therapies. Fortunately, many genetic renal diseases already have treatments, and we've really only just begun to scratch the surface. Genetic testing is also important for the entire family. Identifying the genetic cause for one family member's disorders can help identify other individuals needing care, help with family planning and reproductive decisions, as well as ensure family living kidney donors do not have the same genetic condition. It is really quite an honor to partner with the core kidney team as we continue to improve clinical care, expand research, and increase education about renal disease. I look forward to continuing to build this program and am hopeful that as we better understand the genetics of kidney disease, we will continue to expand the caliber of care we can provide to our patients.
Hi, my name is Dr. Nilu Nobacht. I'm one of the nephrologists at UCLA Core Kidney Program. I want to welcome you all to our symposium focused on kidney stone. We have great expert in field, top faculties at the field of nephrology and urology join us for this course. I hope you find this very useful in your patient care and practice. I also want to briefly touch the point of wellness. We had a beautiful music and medicine event at UCLA Schoenberg Music Hall in 2018. This year, given pandemic, our event will be virtual and will be released soon. This event will be dedicated to all patients, healthcare providers, their families, and community. I wish you all a great, happy holiday and healthy 2021, especially when the vaccine is on the way. Thanks for us. Stay safe.
Hello, everyone. My name is Christina Lopez, and I'm the manager of the UCLA Core Kidney Program. Just a fun fact, I started off as a volunteer. Let's start with a little UCLA Core Kidney Program history. There was notice of an unmet need for education. We saw that education would empower our patients to become their own advocates. In 2009, we started planting the seeds when Joe F. Fantis and I joined the program. Dr. Novak and Dr. Kamgar joined us as fellows. We started with small internal educational programs. Then we had a great problem. It became standing room only. That is when we planned and executed the Kidney Fair at the Beach in 2015, where over 1,500 people attended. After that, we started our monthly UCLA Kidney Enhancement Education programs, also known as UKEEP. Our mission is to improve healthcare delivery by implementing our core values of clinical excellence, outreach, research, and education. Those values truly do run to our core. The Core Kidney Program's vision is aligned with the mission of UCLA Health, healing humankind one patient at a time. Our focus is on comprehensive medicine and integrative medicine with emphasis on prevention and education so patients can become their own best advocates. Nobody should be left behind. The Bruin Beans Health Club is an official undergraduate club at UCLA under the UCLA Core Kidney Program that was founded in 2015 with the goal to mentor future leaders in healthcare. The Green Ribbon Campaign started in 2016 at UCLA by the UCLA Core Kidney Program. And just to let you know, over 31 million people are currently diagnosed with kidney disease and 26 million are at risk. The best way to fight kidney disease is by spreading awareness and educating people to become advocates for their own health. Green ribbons are worn to bring awareness, and that's why I'm wearing my green ribbon. The Circle of Core is a kidney patient support and advocacy group started in 2019. The UCLA Core Kidney website was launched in 2016. The website started under the nephrology site, but became so large that it is now under the UCLA Health Medicine site. As I mentioned before, the core values focus so patients can have tools to become their own best advocates. The Core Kidney website now has a global reach with people contacting us from all over the world. We have clinical programs that provide comprehensive care on a diverse range of disease states, including chronic kidney disease, end-stage kidney disease and transition of care, genetic causes of kidney disease, ADPKD, Fabry, Alport, H, and much more. Diabetic kidney disease, resistant hypertension, home dialysis, diet and nutrition, clinical research programs. The aim of these programs is for a multidisciplinary team to work together and to break down the silos in present-day healthcare system through integrative care. We plan to start many more in the upcoming year. We have ongoing clinical trials, kidney disease, diabetes, hypertension, dialysis, transplantation with a focus on living kidney donation, and anemia. Our outreach emphasis is on underserved communities, focuses on proper lifestyle choices. We explain preventative health with a focus on kidney health and provide easily accessible information through our webinars, UKEEP, kidney fairs, health expositions, symposiums, virtual events with a global outreach. Our Bruin Beans project was to visit an orphanage in Tijuana, Mexico. It was at the end of summer, so the Bruin Beans Health Club members collected school supplies and toiletries to give out to the children. We spent the weekend there. We cooked for them, we played games, and basically learned so much from them. Our original plan was to teach them, but we learned so much from them. When it was time to pass out the school supplies, the kids were so excited. One boy came to me and said that this was the first time that he ever had his own school supplies. And that really touched me. Every day we make a difference and impact many people's lives. Ultimately, our goal is to establish a kidney center at UCLA where comprehensive care for our kidney patients and their entire families, starting from pre-diagnosis to transplant, will be provided. We truly believe that this is the best way to really make a difference. I would like to extend our utmost gratitude to you for all of your help and support through the creation and growth of the UCLA Core Kidney Program. We could not have done this without you. If you would like to learn more about how we uphold the core values, please visit our website. Thank you very much.
Hello and good morning. I'm Dr. Kamgar, one of the nephrologists at UCLA and director of fellowship program. On behalf of UCLA Core Kidney Program, I wanted to welcome you to this year's symposium. I hope you enjoy. We have an outstanding group of speakers from nephrology and urology who are national experts in the field of kidney stones. I hope you enjoy, and thank you so much again for joining us. Happy holiday and stay safe.
All right. Thank you. Thank you very much, Dr. Kamgar. And so just a couple of things. Dr. Dunn, Dr. Scotland are urologists leading the pathway in research as well as the clinical care. We also heard from Dr. Bianca, our geneticist, and Dr. Gostaseb, our medical director. And Christina, for all that she has done, Dr. Novak for the wellness, and then our fellowship director. So this is our key members of our stone program. I know there are a lot more, but these were some of the things that we could put into our program because of time's sake. I do want to do a shout out to my very good friend who's actually on right now, Dr. Bob Provenzano from Detroit. Just saw your name over there. Dr. Provenzano, I'm sure a lot of you know, a dear friend of mine, also leading research in anemia in kidney disease. And hopefully we will get some new medications out. We talk about pharmacology and how we're advancing it. So hopefully we'll get some oral agents for anemia management in 2021. Now with that, we'll get into our presentations. We have a spectacular lineup, the best we can get actually. The faculties are all rock stars, with no pun intended, like I said. Our first faculty is a very dear friend of mine, Dr. David Goldfarb. And Dr. Goldfarb, and needs no introduction, but just to read out his affiliations, he is professor of medicine and physiology and chief of nephrology at NYU Langone Health Institute. And he is also the director of the Kidney Stone Prevention Program. So Dr. Goldfarb has a lot of interesting stories, but one of them was actually published in JAMA. And Anita will be putting that in the chat box, the link to that article that was published in 2013. I have it over here. If I can show it to you. This is Cocktail Party Nephrology. Please do read it. It's quite fascinating. Dr. Goldfarb, with all patient privacy, is actually has kidney stones or had kidney stones himself. So heavily dedicated, not just for kidney stone treatment, but also prevention. And he has 3 talks today. The first one is an overview of kidney stone disease. So Dr. Goldfarb.
Well, Dr. Rastogi, thank you for your warm introduction. Thanks for having me here today. It's really a pleasure to have the opportunity to talk to you about kidney stones today. We'll talk about the number of different kinds of kidney stones, some of the causes, and how to evaluate patients with kidney stones. My disclosures here, of course, as I told you already, my past medical history includes calcium oxalate stones. Why are kidney stones important? Because they are increasing in prevalence. And you can see here that from these NHANES data, orange from the 70s to 80s, blue in the 80s into the 90s, and white into the later up to 2010, that kidney stones are becoming more prevalent in every age group, in whites on the left, in blacks on the right. If I showed you these slides and changed white and black to men and women, you would see the same thing. increasing kidney stone prevalence in all groups. And there's also data, although these are the American data, the data show that this is happening the same in Brazil, Germany, Japan, around the world. The reasons for this are not completely understood. I will speculate a little bit about what the possible etiologies might be. Who's getting kidney stones? It's increasing even in children. And these are David Sass from the Mayo Clinics. His data from from South Carolina actually demonstrate that in boys and girls, there's increasing prevalence from the 90s into the 21st century. So it's not just an adult problem, it's a pediatric problem. And you can ask a pediatric urologist that they are seeing more emergency room visits for children as well. So usually we're now saying that kidney stones will occur in about 10 to 15% of men, 7% of women, with recurrence rates of 30% at 5 years, up to 80% at 20 years. And that's why it's important to say to young people with their first kidney stone, this is something that's likely to come back. This is something we need to do something about. Here's the first and most important kidney stone because it is not just the most representative of the most common kind of kidney stone, it's the stone that was in my right ureteropelvic junction back in 1995. These are the fragments of stones after the shockwave lithotripsy that I had. And if you're interested, the essay, Dr. Rastogi, I think, has posted this. Cocktail Party Nephrology is an essay I wrote in JAMA regarding how I became a kidney stone doctor. This 7mm stone was very painful. It's representative of what most stones are made of. Other calcium stones are made of calcium phosphate, mostly in the form of hydroxyapatite. That's what bone is made out of. This is about 20% of calcium stones, or about 15% of the total stones. If you see calcium phosphate stones, I'll show you that these are more common in younger women and girls. But think about a couple of things. Primary hyperparathyroidism. Those patients have more calcium oxalate than calcium phosphate stones, but more calcium phosphate stones than the general population. And patients with renal tubular acidosis who have a higher urine pH are more likely to form calcium phosphate stones. So those are a couple of diagnoses that should cross your mind when you see a patient with a calcium phosphate stone. We'll talk a little bit about uric acid, about 10 to 15% of stones, but as high as 60% of the stones in diabetics. Typically these yellow, orangish, they can even be reddish stones. And I'll tell you more about that. This is a 1 month production of stones by one of my patients. We won't talk very much about struvite stones, more common in women because, of course, they're prevalent in patients with urinary tract infections, and women do get more UTIs than men. But this total staghorn calculus was removed from a non-functioning kidney, a nephrectomy that was done here at the New York VA. So these can occur in men and women, anybody with a urinary tract infection with organisms that produce urease. And we're not going to talk today about the rare genetic causes of kidney stones, but these are cystine stones. You can see that this is a hollow cylinder that formed on a patient's stent. This is, again, a patient from the New York VA who had cystinuria. These typically lemon yellow kidney stones can be very large and recurrent, and is due to a genetic disease of the proximal tubule and cysteine and dibasic amino acid reabsorption. These are John Lieske's data from a year at the Mayo Clinic looking at kidney stone composition. This C. Jason paper from 2014 shows basically what I just told you: calcium oxalate about 67%, calcium phosphate or hydroxyapatite 16%, uric acid 8%, struvite, brushite, another form of calcium phosphate, cystine stones, and a few others. Just noted that there are drugs that cause some kidney stones. So this is very typical of representative of stones in the United States. And John looked at the association of stone composition with age, and you can see an interesting thing here. Here's calcium oxalate in the boxes, and you can see that men at any age tend to have more calcium oxalate stones, but the open squares are apatite stones, calcium phosphate, and you can see that between 10 and 30, right in that gap there, women will tend to have more calcium phosphate stones. Calcium phosphate stones occur with higher urine pH. And so the implication here is that these younger girls to women will have a higher urine pH. And why that's true? Do they have more renal tubular acidosis? Are they on a different diet? It's not completely understood. So you can see that it's not uncommon for young girls and women to have calcium phosphate stones. And then as they get older, they become, like men, more calcium oxalate stones occur. So when you see a patient who's had a kidney stone, think about some of these things, and all of these items deserve more time than I can give them today, but certainly medications, for instance, topiramate, Topamax. I'm interested in how occupations cause kidney stones. I'll say a little bit more about that. Family history is certainly important, and thinking about other kidney diseases like polycystic kidney disease, and particularly in a kidney stone clinic, you should see a lot of patients with inflammatory bowel disease who have a variety of reasons why their stool output and the metabolic acidosis that comes with it contributes to kidney stones. They may be at risk as well for enteric hyperoxaluria. We take a detailed dietary history and ask people about high protein intake, weight loss diets, purines, their salt intake, fluid intake, oxalate, calcium intake. Calcium helps prevent kidney stones. We'll say more about that later. I believe that many patients go to an emergency room, have an episode of renal colic, but I think everybody needs imaging. Some may not get that in the ER. If that hasn't happened, at least get an ultrasound. Are there other kidney stones present? Does the patient have polycystic kidney disease, nephrocalcinosis, medullary sponge kidney? These are all things that you're interested in as part of the evaluation. Medications, I mentioned topiramate. Here at the New York VA, where we have an HIV population, the protease inhibitors like atazanavir also cause stones. One thing to know about the protease inhibitors is that these stones are so not dense, they're so radiolucent that they will not be seen on CAT scan. These are the only kinds of stones not seen on CAT scan. These are atazanavir stones, a picture taken by my colleague and friend John Esplin at Litholink. Vitamin C, everybody's taking that to prevent COVID. It doesn't work. Ascorbate is metabolized to oxalate. Felbamate is poorly soluble. Triamterene should not be used in patients with kidney stones. And we've seen a few patients with guaifenesin stones. Cough syrup, guaifenesin. Everyone, of course, you're mostly nephrologists and urologists. Everyone's going to have a set of electrolytes, creatinine. Look for even subtle hypercalcemia. And when I say it may not have an H next to it for high, it might be 9.9 or 10.0. Think about whether that patient deserves a PTH measurement to rule out hyperparathyroidism. Kidney stones occasionally are the first presentation of sarcoidosis. And CYP24A1 mutations, we'll talk about that, genetics of that. These are patients who are particularly sensitive to the effects of vitamin D to increase serum calcium and urine calcium excretion. Any lower bicarbonate, consider whether that patient has renal tubular acidosis, because those patients will need treatment with alkali for some period of time. And magnesium and phosphate, loss of magnesium and loss of phosphate can be associated with calcium stones. We get a serum uric acid because it's very common that these are patients who are overweight, have metabolic syndrome, and may have hyperuricemia and gout. I want to know everyone's urinalysis at least one time, not in the emergency room. High urine pH suggests renal tubular acidosis, and a very high urine pH, like 8 to 9, really can only be possible as the result of struvite stones in infection with a proteus or other organisms that produce urease. A low urine pH is typical of uric acid stones. In fact, it's hard to get a uric acid stone if you don't have a low urine pH. Urine cultures are appropriate. Make sure that the patient does not have an infection. And if you're seeing a patient with renal colic, you really want to make sure that they don't have pyuria. Consider getting a urine culture at that time. How much does a stone analysis cost in the United States right now? It costs about $30 to $50. There's no excuse for not getting a kidney stone that has been collected in the OR, in the emergency room by the patient, and sending it for stone composition. Either X-ray diffraction or infrared spectroscopy is the appropriate way to do that. From the point of view of etiologies, one of the risk factors that has been demonstrated by Eric Taylor and Gary Curhan is the effect of body size on stone risk. My friends Eric and Gary look at the Nurses' Health Study and the Health Professional Follow-Up Study. These are important studies because they're large and they're prospective. And they've demonstrated that the prevalence of kidney stones was associated with weight and body mass index. So the odds ratio for stones in people who had a body mass index greater than 30 compared with a lower quintile of people with a lower body mass, men were 33% more likely and women were twice as likely to have kidney stones. So exactly how this works, how the metabolic syndrome, overweight, obesity are associated with kidney stones is not completely clear. Now, a controversial topic, or at least I like to think it's controversial, is the AUA guidelines suggest that clinicians should perform additional metabolic testing in high-risk or interested first-time stone formers, and certainly recurrent stone formers, and certainly in children as well. The evidence for this was considered moderate. That's because there's not many randomized trials demonstrating whether it makes a difference in your therapy to have a 24-hour urine collection. The risk factors that you'd be looking for in patients with calcium stones would be higher urine calcium, higher oxalate, low citrate, because citrate binds to calcium and prevents it from binding to oxalate. High uric acid is a controversial risk factor for calcium stones. Certainly what I call the house staff disease, because I was a house officer when I had my first kidney stone. Low urine volume, people who are walking around sweating, exercising, not eating and drinking very much, have a low urine volume, a concentrated urine. It's very likely, when I tell you about the genetics of kidney stones, that there are people who have too much of something that promotes crystallization or too little of something that inhibits crystallization, but we don't know a lot about the epidemiology. Some of the molecules have been suggested, but this has not really been done on a large scale. So we don't really understand which of these molecules might be important. These are mostly proteins found in the urine. So if metabolic testing should consist of a 24-hour urine collection, and if you use a commercial laboratory like Litholink, you'll get the volume, the pH, the calcium, the oxalate, the citrate, the sodium, the potassium. All of these are useful so that you can figure out what the patient's eating, what their diet's like, and what their risk factors for kidney stones are. You want the creatinine in order to demonstrate that one collection is comparable to another, that they've been done under the same kinds of, that they've been done adequately is a way of thinking about it. And although I can tell you why you can treat a patient without a 24-hour urine collection, I'll point out that one of the best reasons to do a 24-hour urine collection is to rule out primary hyperoxaluria, which John Lieske is going to tell you about. If the urine oxalate is high, and 75 milligrams might be a reasonable cutoff, you really want to think about whether that patient should be genotyped and could have primary hyperoxalurias. So that's something, because these are patients who might look otherwise like patients with calcium oxalate stones, like me, you're only going to find that kind of hyperoxaluria if you do a urine collection, of course. But 24-hour urine collections are not done very frequently. Here's data from 2014. With John Hollingsworth did this at the University of Michigan, and they looked at a group of patients they considered high-risk stone formers and looked at how many patients had 24-hour urine collections done. There's really no difference from the years that are counted here, from 7% to 8%. You can see that most patients don't get a 24-hour urine collection. In fact, it's a little embarrassing to me. If you were seen by a nephrologist, you were almost 3 times likely, but if you were seen by a urologist, you were almost 4 times likely to have a 24-hour urine collection done. So why are most people not getting it? Are most people not getting it because the doctors don't think it's useful, because it's intimidating to look at the results? I honestly am not completely sure, but these are patients who, when they're considered high risk and they've had recurrent stones or big stones, or they've been to the operating room, I'm completely in favor of getting 24-hour urine collections. We talked about this. My urology colleagues, Ryan C., Marshall Stoller, wrote this paper in 2016 where we looked at some of the controversies regarding 24-hour urine collections and how useful they might be, and that you might find that useful to read. Some of the pros you get objective quantifiable data. You provide adherence data. If you gave a drug or you changed the diet, you like to see if the urine collections look different. The patients like this very often because they want to know, why do I have kidney stones? They're not nearly as inconvenient as they used to be. You can limit your prescription of diet and medications to the specific issues affecting your patient. And presumably, we're doing this because it's a surrogate for what's going to happen. Will the patient make kidney stones? If the urine collections look better, the answer will be less likely. But there is a complexity in interpretation. The ability to predict recurrence is not perfect. Many patients, of course, don't like to do this. It does require repeat testing, and I have patients who have done it 10 and 20 times, and I have other patients who really don't want to do it. But if you're persuasive and you're an expert, you tell your patient this is important, usually their insurance is going to pay for it. We do have, even at Bellevue Hospital up the block in First Avenue, where many patients are not insured, if I negotiate a low price for the 24-hour urine collection, they may not be able to pay cash at all. Which urine to review? We have this paper, I'll say a little bit more about this, but cabbies are an example. They're not drinking very much, and we understand that there are people who at work are having a different urine collection than they are on the weekends. Would a spot urine be useful at any time during the day, in the morning, at nighttime, after meals, while people are sleeping? All of these are questions that make it difficult to know which urine is really relevant. Should I do a 24-hour urine collection on Monday, or should I do it on Sunday? Which do you spend more time at work or at home? Is your diet very different? We do want the urine collections to be representative of what the patient is actually doing most of the time. And these data from John Asplin and Fred Coe in the University of Chicago demonstrated that supersaturation of urine correlated with the kidney stone composition. So if you look here on the z-axis, the supersaturation for calcium oxalate, these were patients who, and the higher values, they had calcium stones, they had calcium phosphate, calcium oxalate, and calcium and mixed calcium phosphate oxalate stones. Here, on the supersaturation for brushite axis, you can see that there were the calcium phosphate stone formers. They were highest in having a brushite supersaturation, while the patients who had the lowest urine pH, therefore would have the highest uric acid supersaturation, were more likely to have uric acid stones. So there were good correlations on all three axes with stone composition, and that's why we like to get supersaturation. That only a kidney stone laboratory will calculate that value from the values of all the other analytes. One of the terms that I would try to eliminate, and I know I've said it already once today, is hypercalciuria. And that's based on these data from Gary Curhan, where they looked at patients from the Nurses' Health Study 1 and 2, the Health Professional Follow-Up Study, and they looked at urine calcium on the x-axis, and then looked at the likelihood, the relative risk of stone formation. And you can see that starting at 100 milligrams per day, as calcium went up, the risk of kidney stones increased in all three groups. And Gary points out that, therefore, hypercalciuria is not here around 200 for women, or around here, 250 or so for men. These are not dichotomous points. You have normal calcium or you have high calcium. As urine calcium goes up, kidney stone risk increases. And that means that if you show me a patient with a urine calcium of 250, I don't say, I don't know what's wrong with you, that's a normal number. I'd rather say, I will lower your urine calcium. And that's why the term hypercalciuria is not very useful. The same is true for oxalate. Now, this graph is only showing oxalate values in the normal range. Hyperoxaluria is often defined as greater than 40 or 45 milligrams per day. And in all three groups, for the most part, when you went from 20 to 40, within the normal range, the risk of kidney stones increased. So I like to quote Gary Curhan here. It's clear that the generally accepted definitions of normal are not appropriate. The stone formation rises at levels of urine calcium and oxalate and decreases at levels of urine citrate that traditionally would be considered in the normal range. So the terms hypercalciuria, hyperoxaluria, hypocitraturia don't really mean very much. You want to fix the urine. And if you see a patient with a normal 24-hour urine collection, normal in quotes, You want to make it more normal. You want to make it better. I gave this talk at the NIH in 2015 regarding the exposome. What is the exposome? It's your exposure to various things that lead to diseases. So you get exposed to various things. It's filtered by the unique characteristics. You can consider that your genome, and that causes disease. So you go through this progression here. Example, some people smoke, that's an exposure. Some people smoke all day long and never get lung cancer or COPD. They don't have it. And other people, of course, are sensitive. Some people drink and get cirrhosis, and some people drink and don't have the disease. So tracing the exposure to the disease that occurs is about the exposome, and people are now doing exposomic research to try to keep track of this stuff. I'll also point out, if you haven't thought about epigenetics, this great review in the New England Journal in 2018 made me add this box because it's pretty clear that exposures do lead to changes of the way people respond to exposures and cause disease. This is a nice review of epigenetics. I won't talk about further, but an interesting factor that may be important in understanding kidney stone risk. So one of the exposures that I think all of you are familiar with is the fact that healthcare professionals don't just get COVID, they also can get kidney stones. And these data are from Amy Krambeck's study done at the Mayo Clinic, where people who worked in an operating room had a greater risk of stones than people who didn't work in an operating room. They had more stones, they were more likely to report a low fluid intake, and the number of physicians with stones was almost twice as great as the non-OR physicians. So the hazard ratio for working in an OR was 1.4. And this is simply that idea that you go into the OR for hours, you don't drink anything, and you don't urinate, and you're more likely to make kidney stones. One of the deficiencies of this paper, though, is that it didn't talk about whether these physicians were men or women. I think it's possible that there are more women working in the operating room as physicians nowadays, of course, and that may be one of the factors that contributes to women having more kidney stones and closing the gap so that this is less a disease of men the way it used to be. And Deepa Maliekkal, one of my former fellows, now an assistant professor at Northwell and Hofstra Medical School, we recently put this paper out on occupational kidney stones and tried to deal with some of these interesting issues. This should be part of your history when you see a patient with kidney stones. So increasing prevalence of kidney stones might be due to obesity, metabolic syndrome, diabetes, diet, all of us eating more salt and less dairy. Question was asked of me, what about global warming? Could that contribute to kidney stones? I was skeptical about that because the temperature of the earth has changed by 1 degree. I'm not denying climate change, but I will say that 1 degree didn't seem like something that would lead to more kidney stones. It might lead to more hurricanes and melting of the polar ice caps, but kidney stones, I wasn't sure. The simple idea, though, is that higher temperature leads to more transdermal water loss, sweating, and that leads to a decrease in urine volume, which leads to concentration of urinary electrolytes. Another question, what about bacteria, and what about the microbiome? What about antibiotics? So we've been interested in this topic, Oxalobacter, for a while. Gram-negative obligate anaerobe lives in the colon of many people, and it has one substrate. It eats oxalate. So if you have spinach for lunch, your bacteria, your microbiome, has the potential to degrade some of that oxalate, reduce its absorption from the intestine, and therefore its appearance in the urine. So the presence of Oxalobacter has been associated with diminished urinary oxalate, and its absence associated with hyperoxaluria. We did a study where we looked at patients who had Oxalobacter colonization. About 32% of the patients that we selected the patients who had Oxalobacter, about 32% of the patients that we studied, and we looked at people who were going to get antibiotics for Helicobacter pylori. We wanted to get a stool sample before the patient was treated, and of course this is one of the few patients where they get antibiotics. You could get a stool sample before they were treated because unlike patients with pneumonia or otitis, they're not going to get their antibiotic that day. So all of the patients, 100% by definition, were Oxalobacter positive, and all of them had H. pylori in in the blue box. But the red box were patients who had an endoscopy and did not have Helicobacter, and therefore were not going to get antibiotics. Here's what happened. At 1 month, patients who were treated for H. pylori with antibiotics, 31% of them still had Oxalobacter. Only 86% of the patients who had no antibiotics still had it. They did not have it eliminated. So the organism was persistent in the patients who didn't get antibiotics. At 6 months, this was still true. The microbiome of the intestine had changed. Antibiotics had eliminated Oxalobacter. It was persistent in the patients who didn't get antibiotics. These were statistically significant. So this was the evidence that getting an antibiotic for H. pylori could change the intestinal microbiome. Then the question would be, well, did these patients have more oxalate in their urine because their Oxalobacter was eliminated? Did they get more kidney stones? Well, this was just a study of patients who had an endoscopy. It's a small study, not the right group. So then we published this paper. This is from Greg Tazian, a urologist, pediatric urologist at CHOP in Philadelphia. This actually was published in JASN in 2019. It's the first study to show that risk of kidney stones increased with antibiotics. So you can see here that in blue, the risk of having a kidney stone within a year after a course of antibiotics was increased in patients who were treated with sulfa, cephalosporins, quinolones, nitrofurantoin, and broad-spectrum penicillin. In red, after a year, these numbers went down. In other words, you were still more likely to have a kidney stone, but it was less than it was in the first year. So presumably, our hypothesis was, first, antibiotics are actually leading to kidney stones. Number two, possibly that's happening through the microbiome. Three, potentially through changes in the Oxalobacter prevalence. Patients who were treated with H. pylori did have an increased odds ratio of having a kidney stone in the first year in blue. That returned to normal in the horizontal bar at, the vertical bar at 1.0, presumably after the microbiome has had an opportunity to reconstitute. Talk about uric acid stones a bit. This is a 1 month supply of uric acid stones by my patient, Mr. Rotundi. And it's important to mention his last name because that's also the body shape that Mr. Rotundi had, rotund. And here, let me just emphasize that the most important risk factor is the low urine pH. This is Naeem Malouf's paper in 2004. Yes, high uric acid contributes. People with myeloproliferative disorders like polycythemia, uricose-uric medications like lesinurad, congenital disorders, of course, leishmanian. But the most important thing, obesity, insulin resistance, leading to diabetes or the metabolic syndrome leads to a low urine pH, and under that circumstance, uric acid stones form. Uric acid, the bad stuff, is this protonated molecule over here on the right. Because the pK is 5.3, if you increase the urine pH and get it up to 6.5, one pH away from the pK, then uric acid gives up its proton. It's charged now. There's the urate anion. Now that's perfectly soluble. So people don't get urate stones. People get uric acid stones. Uric acid is the insoluble species, and your goal is to alkalinize the urine and prevent uric acid from crystallizing. These are interesting data from Dordogne in France, shows the percent of uric acid stones. And you can see here that as you increase body mass index from less than 25 to a medium number to overweight, the percent of uric acid stones increases. In the non-diabetics, the diabetics are 2 to 3 times as high, more likely to have uric acid stones. Body mass index is a risk factor for uric acid stones, and so is diabetes. This is because as weight goes up, insulin resistance is prevalent, and urine pH goes down. This is true for diabetics and non-diabetics. That's the introduction to kidney stone talk. My story on cocktail party nephrology is an essay that Dr. Rastogi has published, if you're interested in that. My acknowledgements. Well, so that's what I wanted to tell you about the introduction to kidney stones. I couldn't cover all the topics, but I appreciate the opportunity again and give it back to you, Dr. Rastogi.
Thank you, Dr. Goldfarb. That was quite amazing presentation. So now looking at, I just wanted to, please look at the chat box. Also, if there are any questions, please put them in the Q&A box so we can get them. We'll try to answer all the questions that we get today, either in the Q&A box or at the panel discussion that we're going to have at the end. Now, in case we are not able to answer those questions today, we will be getting back to you. We have your contact information. We will get back to you with the answers. So please feel free, and any comments as well. If you like something, will be better. If there's any concerns, put that in the Q&A. It comes to all of us as panelists. So that was about the Q&A and chat. I also want to do a couple of more shout outs. This is from coast to coast, but we have obviously the East Coast, but going to the West, we have Hawaii, and my very dear friend, Dr. Rick Hayashi. He is in Hawaii, and he's actually joining us, and his daughter, Allison, is my goddaughter. So we did our training together, and I'm very happy that Dr. Rick Hayashi could join us all the way from Hawaii. I did mention that all of our guest faculty are true rock stars. The other thing that I wanted to mention is this article, the medical management of kidney stones AUA guidelines. And as you can see, Dr. Pearle and Dr. Goldfarb are the lead authors in this. Anita is going to put this in the chat box, the link for this. If you do get a chance, please do go and read this article. It's actually quite fascinating. And Dr. Goldfarb and Dr. Pearle are also online. So once again, and so is Dr. Dunn and Dr. Scotland. And if you have any questions, feel free to put them in the chat box, or the Q&A, sorry, not the chat box. We will get back to those questions. Now, moving ahead, our next presentation is from Dr. Goldfarb as well, and it's going to be talking about genetics and kidney stones. As I mentioned, genetics is something that we'll be focusing a lot more. I know Dr. Scotland's research is also in genetics. You heard from Dr. Bianca Russell. You'll be hearing from Dr. Lieske, about primary hyperoxaluria and kidney stones. But the next topic is going to be from Dr. Goldfarb, and he's going to give an overview on genetics in kidney stones. Dr. Goldfarb.
All right, Dr. Rastogi, thank you. We're going to talk now about the genetics of kidney stones. We're interested in this for a long time because we've been members of the Rare Kidney Stone Consortium. We'll talk about how to make these diagnoses and some of the disorders that are particularly of interest because they have therapeutic implications. We'll look at some of the causes of kidney stones from a genetic point of view. I told you before about the exposome, taking those exposures. They're filtered by this box, our unique characteristics. We could relabel that box the genome, deciding what diseases we might have. So I mentioned heat as an example. Some people are exposed to heat, sweat a lot, don't get kidney stones, and some people do. So there's clearly a genetic component to kidney stones, and I'll show you some of the data supporting that idea and talk about this middle box at this time. The Rare Kidney Stone Consortium was funded by NIH from 2009 to 2019 and still exists. At the Mayo Clinic, Dawn Milliner, John Lieske, and David Sass have been part of every project, but particularly the experts on primary hyperoxaluria, dent disease. And David has been putting together a registry of patients with CYP24A1 mutations. At NYU, Lotta Berolasic and I studied dent disease, and I was the principal investigator for the cystinuria group. And our colleagues in Iceland, Vidar Edvardsson, Ron Paulson, and Hilda Ronaldsdottir are the experts on APRT deficiency, adenine phosphorybosyl transferase deficiency, a cause of dihydroxyadenine stones. These are the classic hexagonal crystals seen in patients with cystinuria. And I had one opportunity to see that under a microscope and say, this patient has cystinuria. Our review of these 4 types of stones was published in Pediatric Nephrology in 2013. And I point this out here. If you're interested, all of these 4 diseases are reviewed here, not really out of date, except for the topics that John will talk about with respect to primary hyperoxaluria. Still useful from the point of view of how to make these diagnoses and how to treat these patients. But what about the general population? This is how you do a twin registry, and this is something that we did a while ago. This is the Vietnam era twin registry. It's all veterans and therefore all men at that time. Only men were included in that registry. That's different. I'll show you in the next twin study. But at that time, you basically, the idea here would be that you look at twin 1 and twin 2 and divide the twins into groups. Both members of the twin pair has this disease, kidney stones. That's A. One member does not have it, and one member does have it. Those are the discordant pairs, B and C. Eliminate the twin pairs that are not affected at all by kidney stones, and then you can calculate a concordance rate. So A, the number of pairs where both members of the twin pair are affected, divided by the affected twin pairs, A, B, and C. That's a concordance rate. And so we published this in Kidney International in 2005 and demonstrated that the monozygotic twins, in other words, the genetically identical twins, had a concordance rate of 19% compared to the dizygotic twins at 9%. This was highly statistically significant and suggests, according to the calculations that the twin researchers make, that heritability accounts for 56% of kidney stones. I think these are the best data demonstrating that kidney stones in the general population are heritable. Now, we don't know what the genes are that are responsible, just like if we could show the same kind of results for hypertension or diabetes, we would not know all of the genes that contributed to that heritability. Environmental effects were considered 44% responsible for these effects here. But it was definitely an issue that this twin registry was only men. We were very much interested in demonstrating whether this was true in women as well. And so we published this in KI Reports in 2019. This is the Washington State Twin Registry. It's done at Washington State College. And we looked again at concordance rates. The monozygotic men had a rate of 68% compared to the dizygotic men of 41%. So we reproduced our previous findings in the VA Twin Registry. And now we showed for the first time, and there's a typo here, this is the dizygotic women over here. You can see that the monozygotic women were 43% of concordance compared to 21% in the dizygotic women. The twin researchers make some calculations and show that the heritability here is 46% in women, 57% in men, almost exactly the same as we had shown in our previous twin study. And this is different. It basically suggests that kidney stones are somewhat less heritable in women than they are in men. So that's interesting. And Lada Beralasic and I have a review looking at some of the issues. Why are men and women different from the point of view of kidney stones? But we don't really know which genes account for this interesting finding. So this leads me to mention missing heritability. That's the failure of a genome-wide association study to account for the heritability of a trait. So if you looked at the genetics of patients, and we go back and look at this twin study, heritability is 56%. I can tell you that we don't know what the genes are that make kidney stones so heritable. And I mentioned that you would be able to demonstrate a similar finding in patients with diabetes and hypertension. Highly heritable, but the gene not accounted for. So that's what's meant by missing heritability. We really consider this a heritable disease, but we don't have the genes, even from the couple of genome-wide association studies that have been done for kidney stones. We don't know how to account for this high rate of heritability. Vizzoli in Italy, this editorial to look at some of the factors, some of the monogenic factors causing kidney stones, and going through the nephron, basically skipping, as I like to do, skipping the glomerulus, really not an important part of the nephron. Let's get right to the tubules. The calcium sensing receptor, phosphate transporters, clotho, aquaporins, a variety of other anion exchangers have been associated with kidney stones. And there are some data to show some families or affected individuals, but these are not generally found in the general population. There's alkaline phosphatase, there's a protein involved in calcium flux, other anion exchangers. I mentioned some of these, TRPV5 and some channels that are responsible for ion transport, and a variety of other molecules related to a variety of proteins present in the kidney. All of these are potential contributors to heritability of kidney stones, but none of them account for that missing heritability, that 56% heritable value that we showed in our twin registries. A lot of interesting renal physiology comes out of these kinds of studies, but it doesn't necessarily account for the heritability in the general population. This is a study from Hildebrandt's group in Boston, at BU and Harvard. Diane Braun looked at the prevalence of monogenic causes in pediatric patients with kidney stones. They took patients who had at least one episode of kidney stones or an ultrasound diagnosis of nephrocalcinosis, and then looked at a genetic panel to see how many diagnoses they could make. There were 16 cases out of the 123 with kidney stones, and 8 out of the 20 with nephrocalcinosis who had a variety of genetic mutations that accounted for their disorder. So we think that this is a potential strategy in patients, and as the price of genotyping patients goes down using this kind of genetic panel, it will become more likely that we'll make some of these diagnoses. The demonstration here from that same paper was that some of these patients had early onset within a year of age of the diagnosis of nephrocalcinosis or kidney stones, and a group of others had greater than 1 year. And here are some of the molecules that I talked about. OCRL is responsible for Lowe syndrome. There are claudins here. This is proton ATPase. There are molecules responsible for cystinuria here. There's a variety of molecules that have been associated with monogenic causes of kidney stones. So some of these, maybe 10% conclusion of all kidney stone patients have a monogenic cause, and some of the more common ones include cystinuria. Certainly it's important today, as John Lieske will tell you, to find hyperoxaluria, claudins associated with magnesium loss, and hypomagnesemia as a result. TRPV5 channels were really first suggested by the Icelandic group, the calcium sensing receptor, and the CLCN5 is a molecule responsible for dent disease, active in the proximal tubule. One other molecule that I think is important because it may be particularly prevalent is CYP24A1. This is a cytochrome oxidase, and it's responsible for inactivating active vitamin D. So you know that vitamin D, of course, is 25 hydroxylated. It's then 1 hydroxylated in the kidney and elsewhere in the body to turn into the active form of 125 dihydroxy vitamin D. Most people don't become toxic with vitamin D because they have 24-hydroxylase, the enzyme that turns 125 dihydroxy vitamin D into 124-25 trihydroxy vitamin D, which is also known as calcitriolic acid. But if you don't have 24-hydroxylase because you have mutations in CYP24A1, you wind up with high levels of 25D because you don't 24-hydroxylate it. You get high levels of 125, and those levels stay high because you cannot inactivate them. So these patients then have active 125D. They have increased levels. If they take vitamin D, they're particularly prone to developing hypercalcemia and increased urinary calcium excretion. The other phenotypic finding will be a suppressed PTH. So here's a patient that I just diagnosed last year. She was 8 years old, had hematuria, was found to have nephrocalcinosis, a high urine calcium, and over the next 18 years, she had 1 small stone over that period of time. She was genotyped because it was available at that time when she was a teenager for CLCN5, ruled out dent disease. And then she was sent to me by her pediatric nephrologist to follow up with her. And at age 26, she had a creatinine of 1, so that was a good thing. Her nephrocalcinosis was not a bad thing. Her serum calcium, which had been high in the past, was not so high. And her PTH, and this is really a classic, PTH was quite low. So you might think, oh, this patient has hypercalcemia, let's measure the PTH, rule out hyperparathyroidism. Her PTH was suppressed. Finally, we're able to get her genotyped, as the Rare Kidney Stone Consortium was genotyping a larger group of patients and demonstrated that she had biallelic CYP24A1 mutation. So it's not clear, her mother and she don't recall that she got vitamin D when she was a child, exactly why she had nephrocalcinosis and high urine calcium and kidney stone as a young person is not clear, but she's doing very well with normal kidney function. Some of these patients get renal failure, wind up with end-stage kidney disease. So David Sass, there's his email, sass.david@mayo.edu, is putting together a CYP24A1 mutation. We are genotyping patients at the Mayo Clinic. You send a saliva sample to the Mayo, and we can set you up with that. You can email David if you know a patient who has CYP24A1 mutations and get them into the registry. Hypercalcemia, low PTH, very often an elevated 125 dihydroxyvitamin D. You can also measure and demonstrate that they'll have low levels of 24, 25 dihydroxyvitamin D, a normal metabolite of 25D. So I showed you the slide just to emphasize that some of these are more likely to be found, but they're not likely to make up a large number of cases of the total patients with kidney stones that are out there. We do think that genetic testing has practical implications, and one of the most important reasons may be to find patients with primary hyperoxaluria now, as Dr. Lieske has or will tell you, that there are effective therapies for this disease. The prices are going down continually, and you can email the Mayo Hyperoxaluria Center, hyperoxaluria@mayo.edu, if you'd like your patient to get genotyped. There's also a panel done by Invitae. It's sponsored by Reata. It's focused on focal segmental glomerulosclerosis and Alport syndrome, but it will also look at the genes for primary hyperoxaluria, which, after all, is a cause of chronic kidney disease and progressive chronic kidney disease. There's also a panel done by Natera, a company that's interested in doing this, and for the most part, insurance will usually pay for this genetic screening, at most $350 for that panel to be done. Thank you again for this opportunity. Here are my contact information, my email address. If you want to follow me on Twitter, I'm at Wetalite. Of course, you know what that is. That's calcium oxalate monohydrate. And I'd be glad to be in touch with you if you have issues, want to get patients genotyped, or to talk about kidney stones.
All right. That's another excellent presentation from Dr. Goldfarb. And we are truly putting him to work. So I hope he stays as my friend after this symposium. Also really liked his green ribbon. So that was on genetics and kidney stone. Like I said, genetics is a very broader term, more than just kidney stones. And we discussed that. With that, now we are heading into our first break. So I want to take this moment to thank all our sponsors and exhibitors, without whose support this program would not have been possible. Our major sponsors are Alnylam and Natera. So thank you very much for sponsoring this or supporting this. Actually, that's probably the right word, not the sponsors, but supporting our program. And also our exhibitors. Please do take a moment. There were giving instruction in the chat box how to attend these exhibits. But please do take a moment to go and visit our different exhibitors. AstraZeneca, thank you very much for exhibiting NephCure. They have a lot of good stuff. We spoke about Natera already, the RENA site, the 400 gene panels, 380, but it's growing. Aurinia, thank you very much. Lupus nephritis, we didn't mention that, but once again, slowing down progression of kidney disease, lupus nephritis, a very big role. And last but not the least is also Fresenius, home dialysis, please visit there and learn more about home dialysis, PD, and Velphoro. So with that, we're going to take a 15-minute break. I just want to thank everybody for attending. We'll be back in 15 minutes. I hope you really do enjoy the exhibits. And if you have any more questions, please keep putting them in the Q&A. Thank you very much. We'll be back in 15.
I would like to share my story. I am a kidney transplant recipient about to celebrate my 11th kidney anniversary. I initially was diagnosed with kidney failure at the age of 9. Rapidly progressing glomerulonephritis is what took my kidneys. Initially, my reaction to my diagnosis was fear. I was very sad and upset, thinking that my life was going to be changed forever, which it has been. However, I know that it's not over now. Thankfully, I was given the option to start home therapies, and I chose peritoneal dialysis at the age of 21 when I did start dialysis. During that time, I never let my disease slow me down. I played volleyball in high school, I got good grades, and I worked a full-time job. I started in the nursing program and had an aspiration to become a nurse in nephrology. I unfortunately lost my PD catheter to a recurring peritonitis, and I was put back on hemodialysis. And during this whole time, I was in school. I never missed a day of school or let my disease slow down my dreams. I'm really hopeful that patients and family members can understand that this type of diagnosis, though it is major, it does not define the person, and that the person can live a fulfilling life. After graduating nursing school and working in peritoneal dialysis, I decided I wanted to go back to school and get my master's degree. I work as a nurse practitioner currently in a hemodialysis facility, and I love my job. Every day I get to give back to the community that I was once a part of and help patients get through the trials and tribulations that dialysis can give you. I thankfully have transplanted as well during school, undergrad program, where I had a live donor who donated her kidney to me. Renee, my live donor, is 10 years older than me and is a friend of mine and will be for life.
Thank you for being here tonight. Thank you to the students, staff, and faculty from the Department of Medicine and Department of Music.
And why music? I'm happy to introduce music and its role in medicine briefly.
Sometimes our life challenges bring us opportunities that you never even thought about.
His mission has always been to help people and make the right choices to give people hope.
And the biggest challenge is that kidney disease is a silent disease, so it doesn't cause any symptoms till the very end. And when it causes symptoms, they're pretty bad.
If you want to be with extraordinary people who are going to be doing something very extraordinary, and you can be part of it, I will tell you, jump on the team.
There are several risk factors that's easily modifiable and can be changed that prevent from developing chronic kidney disease.
These doctors are really putting in their weekends, all of their time and effort to raise awareness for all of us in this disease.
Hi, I'm Dr. Adu, UCLA nephrologist practicing in downtown Los Angeles. And I want to encourage you to know your estimated glomerular filtration rate, or eGFR for short. This is a wonderful way to know how well your kidneys are working and can be determined by a simple blood test. An eGFR less than 60 for 3 or more months indicates chronic kidney disease. Call us at 310-206-7662 to schedule an appointment for further evaluation. I look forward to working with you to help manage and prevent the progression of your kidney disease.
My name's Louis Simon. I have AD-PKD, and I'm also a clinical researcher in Dr. Rastogi's research office at UCLA. So for me, PKD is very much a family affair. It runs in my dad's side of the family. So my dad has it, his brother has it, their mother had it, and now I have it. I remember growing up, I would see, my dad had to take a lot of medications and had to go to the doctors quite a bit. I was kind of seeing the later progression, or the later stages of progression of the disease. And it was all leading to him needing to be on dialysis. That was in 2005. He needed to be listed for transplant. soon after. But I mean, as some of you probably know, the waiting list for deceased donor transplant is very long, ranging from maybe 5 years to upwards of 10 years. So knowing that, my mom was kind of on a whim, went to see if she could potentially donate a kidney to my dad. And she went to UCLA, got evaluated, and luckily enough for all of us, she was a match. So she was able to successfully donate her kidney to my dad in 2006, and the transplant was successful. And like I said, we're very fortunate.
I donated my kidney at UCLA in June of 2019. People always ask donors, why did you do that? Well, my answer is just because I was inspired, because it was the right thing to do, because it isn't often that we have the opportunity to make a difference. I don't have a family member who is in dire need of a kidney. So I donated to a stranger. And it truly is one of the most transformational things I've ever done with my life. I'm healthy as a horse. I was actually very, very proud that at 65 years old, I was considered strong enough and healthy enough to donate. And now, a year later, I feel absolutely great. But I think emotionally, it gave me a growth spurt. I learned a lot about myself. I learned about humanity, and I learned that we all have the opportunity to touch somebody's life and to truly make a difference. The Advanced Donor Program is a unique opportunity to name up to 5 family members to prioritize should they ever need a kidney. So my act of generosity actually is a little bit of paying it forward. If my children or my grandchildren or my brother-in-law ever needs a kidney, they're going to get top priority. So I feel good. I feel good that I was able to do this. I feel good that I was being able to kind of set a place for my children and my family. And I thank you, each of you, for caring and being interested in kidney disease and how you can help in somebody else's life.
All right. Welcome back, everyone. I hope you enjoyed your this break, and also did get a chance to attend the exhibit booths, the virtual exhibit booths. And just to go over the list again, it's we're very grateful to our exhibitors, AstraZeneca, Neph-Centric, Natera, Aurinia, and Fresenius. So those are the exhibitors, and our sponsors are Alnylam and Natera. So thank you very, very much for sponsoring and exhibiting. Now, our next presentation is going to be from Dr. John Lieske. Dr. John Lieske is a professor of medicine at Mayo Clinic, Rochester, and he has done very critical research, important research in the field of primary hyperoxaluria. So he'll be going over that in a lot more detail. And in the meantime, please have the questions keep on coming at Q&A. So as we get the questions, we will keep on answering them. So with that, Dr. Lieske.
So thank you very much, Dr. Rastogi. I'm happy to be here and share with you some new developments in primary hyperoxaluria and new treatments that are available for this. So these are my disclosures. So I do have industry funding noted there in the field of oxalate research. So I thought I'd start out with a recent case. It's a 55-year-old female. She's native of India, has been living in the United States for a number of decades. She'd had multiple kidney stones, and they had started fairly early in her mid-20s. She required 3 shockwave lithotripsy procedures, 1 ureteroscopy. She had passed 3 to 4 other stones. Most recent was about 4 years before we had seen her in 2013. Of note, she did have a brother who had died at age 10 with kidney stones and kidney failure. Parents had both had 1 kidney stone each, but no kidney failure otherwise in the family, and there was no known consanguinity in the family. So her creatinine had been very normal, so her kidney function had been good in 2014 and 2015, but in 2017, which was about 4 months before we saw her, it had jumped to 1.6, and then the next month it was 2.07, and by October it was 2.5. She'd had a kidney biopsy in early October because of this rising creatinine, which showed evidence of calcium oxalate crystal deposits. She'd had some issues in the time since then with dehydration, an episode of SVT that required a hospitalization, somewhat rocky course there. And by the way, she did mention she took a lot of herbal remedies. So she had a rather peculiar program that wasn't very clear that she was on to try to control her health and kidney stones. These were her labs at the time we saw her in late November. So her creatinine was still relatively high, 2.6, which gave her an estimated GFR of about 20. And by cystatin C, her GFR was also 20, so pretty advanced chronic kidney disease. And her plasma oxalate here was also high initially at 41.7, which is pretty ominous in this disease. Normal for that should be less than 1.5. So both of those would get your attention if you were seeing this person. Her urine studies are shown here, 24-hour urine supersaturation profile. Of note, her urine oxalate here was 170 milligrams, which is a very high number. Normal for that would be less than about 40 or so. And her supersaturation, therefore, for calcium oxalate was very high. This panel here is the metabolites, which might indicate one of the specific kinds of primary hyperoxaluria for glycolate, glycerate, and 4-hydroxyoxyglutarate. Actually, those were all normal on this, so that was one thing that went against the genetic cause. This was her CT study. So she did have a number of stones in both kidneys, and her kidneys themselves looked a little bit scarred, perhaps. But overall, not a ton of kidney stones. We were able to get genetic testing for AGXT through our research consortium, and this did confirm that indeed this is primary hyperoxaluria type 1. She had a homozygous C568 beta A change. So this was diagnostic of type 1 primary hyperoxaluria. Unfortunately, she progressed fairly quickly to end-stage kidney disease by the end of that year and was started on dialysis, and we dialyzed her aggressively 5 to 6 times a week for about 10 months. And then eventually before the end of that year, she was able to get a kidney and liver transplant and did reasonably well after that. So what is oxalate? That's shown here. So the oxalate's a 2-carbon 4-oxygen molecule. It's negatively charged. And the problem with oxalate is, number one, humans have no way to metabolize it. So whatever oxalate that comes into our bodies, either through food or from endogenous metabolism, has to be excreted by the kidneys, and also likes to bind to calcium. So when it's excreted into the urine, it tends to form calcium oxalate crystals shown there. And then if you have enough of this, you can develop kidney stones as well as oxalate nephropathy. These are some of the foods that are high in oxalate. And in fact, all these foods where we get our oxalate, in general, in plants, it actually exists as calcium oxalate crystals as well in the specific vacuoles inside the plant. Some plants are higher than others. You really need to get a list much more detailed than this if you really want to understand what someone's dietary oxalate intake is, because it's not listed on food labels. But in this case, it was genetic, so it was coming from her own liver. And so she had primary hyperoxaluria. So primary hyperoxaluria, though, on the other hand, is due to overproduction of oxalate in your bodies themselves. And that's shown here, that there are currently three known genetic forms of primary hyperoxaluria. Type 1 due to mutations in AGT, type 2 to GRHPR, and type 3 to HOGA. And those different proteins are shown here. In the case of type 1 with AG2 mutations, you have increased backup of glyoxylate, and then this is converted by LDH to oxalate. And in the case of type 2, it's GRHPR. And again, this leads to backup and buildup of glyoxylate, and then this is further metabolized down to oxalate by LDH. Type 3, which is the most recently described form, it's actually not so clear why these patients get hyperoxaluria, because the mutation here really should not lead to anything that we know of that would cause oxalate in the behind that particular enzyme. But there is evidence that this metabolite, 4-hydroxyoxyglutarate, does inhibit GRHPR, which is the type 2 enzyme inside the mitochondria. And presumably this leads to increased glyoxylate, and then that also can then be converted into oxalate. The ancillary tests, so in pH type 1, glycolate tends to be high, in pH 2 glycerate, and then in pH 3 this 4-hydroxyglutamate tends to be high. So this is a diagnostic algorithm of primary hyperoxaluria and what might make you think and test for this further. So in patients with normal kidney function, kidney stones or nephrocalcinosis in childhood would be a tip-off. Recurrent calcium oxalate stones or nephrocalcinosis in an adult like the person that we saw, and especially if there's a family history of primary hyperoxaluria. If that's the case, we definitely want to get urine studies that would include urine oxalate. If it's high in the cutoff that's generally accepted is over 0.7 millimoles, which would be roughly 70 milligrams per day. If it's a young child, you have to correct for body surface area. Then you might want to repeat that testing just to confirm it. At that point, the urine metabolites, including the glycolate, glycerate, HOGA, would be helpful. And if you do confirm it, at that point, you're going to want to go into genetic testing, which is shown on the next slide. If, on the other hand, the urine metabolites in particular are normal, you really want to think, could there be a secondary cause? And the big things here would be malabsorption, so fat malabsorption, any kind of gastrointestinal disease which might lead to fat malabsorption, and then certain diets. People can be on a very high oxalate and or low calcium diet and get hyperoxaluria just from that. And then sometimes in younger kids, it's harder to rule in, rule out genetic causes just from the lab tests, just because the labs change a lot in the first year or two of life. If the person has chronic kidney disease, meaning a GFR less than 30, it may be more problematic to try to diagnose this, especially when they get closer to dialysis and they don't make enough urine to really accurately measure their oxalate. In that case, supportive things that make you think about pH would be a history of calcium oxalate stones, history of oxalate on a biopsy, either of the kidney or elsewhere, or nephrocalcinosis. In this case, urine oxalate, if they're still making urine, can still be very helpful. It really stays pretty high until very late in chronic kidney disease. But in the plasma oxalate becomes even more helpful here, that I'll show later. But plasma oxalate tends to go up quite high in pH as GFR goes down. And that can often be the quickest thing you can do to rule this in as a possibility or not. And we have as the cutoff for us is really over 20. That in regular chronic kidney disease, you might see plasma oxalates up to 20, but if it gets much more than that, really think about pH. And this is here we were in the last slide. So in general here, if it's either very suggestive or we can't really rule out GI causes, the next step is going to be to do the genetic testing. And typically nowadays we would go ahead and do all 3 genes at once. I mean, you can prioritize this. A lot of labs will do 1 gene at a time based on the urine metabolites, but it's probably easier just to do all 3 genes. It's easy enough now to get panel testing, and there are several commercial firms that are even offering this for free now for pH. So I would probably go that route if there's a strong enough suspicion. And this would, if yes, they find a mutation, then we can make the diagnosis of type 1, type 2, type 3. If they do not have a mutation, really there's not a lot of other diagnostic studies we can do right now. I would say consider enrolling them in a research protocol, which there are a lot of researchers doing work in primary hyperoxaluria. We do think there are probably patients that do have a genetic cause that isn't one of these 3 genes, or maybe there's something more complicated going on, but these are the type of people it would be good to get enrolled in research studies so we can get enough of these type patients to do further studies and see if there is a pH type 4 or pH type 5, that sort of thing. In this particular disease, urine oxalate is really a key prognostic indicator. And this is data here from our Rare Kidney Stone Consortium registry. And it's showing the percent of patients free of end-stage renal failure years after diagnosis, going out to 30 years. And the urine oxalate here is divided by quartiles in our population, so each 25%. So the lower group was less than 1.1. This is millimoles per day. And again, for that, normal is 0.46. Then the next quartile, 1.1 to 1.6, 1.6 to 2.4, and then greater than 2.4. And especially in this high urine oxalate group, that was a very bad prognostic indicator, so over 2.4 millimoles per day. The likelihood of end-stage renal failure by the time you were 30 or 40 was pretty high, over 80%. And the 1.6 to 2.4 group was intermediate. And these people in these upper quartiles here, which were less than 1.6 or less than 1.1, tended to do better, although obviously you're not out of the woods, and some of those people will still go on to end-stage kidney disease. So this was some key evidence that makes this a very good biomarker for clinical studies, and also was important for FDA as far as approving some of these therapies based just on urine oxalate alone. This is some newer data from the registry, looking at it by pH type. And really, again, it highlights the fact of 2 things. Number one, we know that urine oxalate tends to run higher in pH 1 than pH 2, and then pH 2 is higher than pH 3. And it's not surprising then that the kidney prognosis, so out to age 60, almost 90% of the pH 1 population has traditionally reached end-stage kidney disease. For pH 2, data like 5 years ago in our registry suggested not so many went on to kidney failure, but as time has gone on and we've gotten more patients, it's clear that pH 2, although it's probably not as severe, still a significant proportion will develop kidney failure. And then pH 3, it's rarer, but as this is the newer, newly discovered disease, we're defining more and more cases as we build an experience. So I wouldn't say that you have no risk of end-stage kidney disease. It's low. And then there are some cases being reported, and I think more to come for pH 3. I think we're going to find that it is a risk factor, but it's not going to be the same as pH 1, for example. Key manifestations of this are kidney stones and nephrocalcinosis. So here, if we look at stone events, this is all types of pH together. And it's in general about 0.3 stones per year, which would mean every 3 to 4 years you pass a kidney stone. Procedures, more like every 7 or 8 years. And then stone events total per year, it's 1 every couple years. And if we look at it cross-sectionally on imaging, this population will have on average 3 to 4 stones at any given time on their imaging. And then nephrocalcinosis, pretty common. So about 30% or 37% will develop nephrocalcinosis, and pretty often this is a harbinger of end-stage kidney disease. And this again is newer data from our registry that we've been pulling together over the last 6 months. And in this case, we're showing pH 3 is in the first column because we're really trying to understand a little better about type 3 pH and how that compares to the other two that we have more experience with. And nephrocalcinosis here is less common in pH 3. So it's not 0 though, so it's 6 or 7% so far, compared to 25% in type 1 and 15% in type 2. The GFR diagnosis does tend to be best in pH 3, so pretty normal in most people, but reduced in pH 1. Plasma oxalate tends to run higher in pH 1, although you have to factor in the kidney function when you're thinking about that. And they do tend to have worse kidney function, which is part of why that's higher. Urine oxalate tends to be highest in pH 1 compared to especially pH 3. Urine calcium really runs quite low in pH type 1. This is fairly characteristic. It's not clear exactly why this is, but in pH 3 it tends to run a little higher, and there are actually a subset of the pH 3 patients that tend to also have some hypercalciuria that we don't completely understand at this point, and they contribute to their active kidney stone disease. And this is a newer graph where we're trying to look at stone events over time, because there had been this impression that pH 3 was mostly a disease of younger kids and went into remission as you got older, but in point of fact, we're finding that stone events, at least in the registry with cross-sectional data, seem to be pretty constant over the lifespan. And this is just showing individual patients with 1 dot per decade, the number of stone events they've had. And it really goes out through the decades. And it's, if anything, more common stones overall in pH 3 compared to the other two types of pH would be the other take-home message. But in all forms, we do see stones kind of throughout the age spectrum. Probably tapers off in pH 1 in particular, because a lot of these people will then have gone on to chronic kidney disease and or end stage. Nephrocalcinosis, when we've looked at this in the total pH population, this is an ominous harbinger. And in general, we do see evidence of nephrocalcinosis before patients go on to end-stage renal failure. And it really increases your risk quite a bit, especially over the next few years that you're going to have issues with your kidney function. pH type 1 is interesting, the AGT enzyme. It's a dimer, and it has to fold and form a dimer. It should ordinarily here be in the peroxisome, shown here inside of liver cells and to some extent other cells in our body, but it's mostly important for hepatic function. And it's targeted that way. It's sort of the default pathway for a lot of proteins to go to the peroxisome, whereas to go to the mitochondrion, there has to be a specific mitochondrial targeting sequence. And what happens in specific mutations in type 1 pH, the protein does not fold correctly, and it leaves a piece of the protein sticking out that can masquerade as a mitochondrial targeting sequence. And this protein actually then gets transported into mitochondria, where it can function potentially, but that's not where it's supposed to be, and that's not where those other metabolites are being made, which is over here in the peroxisome. So these people get hyperoxaluria. It turns out that pyridoxine is a cofactor for AGT protein, and if you give large doses of pyridoxine or vitamin B6, it helps the protein fold better, and then it ends up targeting to the peroxisome. So in particular, patients that have 2 of these G170R mutations respond very well to this pyridoxine. And this is work that we did here at Mayo a number of years ago, showing that this very common mutation, the G170R mutation, if you have 2 copies of the allele, you are going to be completely responsive. If you are, and this is like on the dark bars are people on pyridoxine, the white bars not on pyridoxine. So if you have 2 copies of this mutation, pyridoxine is fully effective. 1 copy, it's partially effective, and no copies, you're unresponsive to pyridoxine. So if you especially have a patient that is, say, on dialysis, you can't really do these kind of studies testing whether or not they will respond or not respond. The genotype can help you understand which patients you should definitely have on pyridoxine with type 1. There are some other genotypes that will respond to pyridoxine. So despite the genotype, we would always do a therapeutic trial of pyridoxine in the range of 5 to 10 milligrams per day. That's a pretty large dose. So typically you can get pills, say, that are 100 milligrams. So they're going to have to take 7 or 8 of those a day to get enough. But it is very cheap, fortunately. And it doesn't have to be divided up. You just give it once a day. And typically, if they're going to respond, they should within a month or two. This is showing the different genotypes. This was some older data about 5 years ago when we looked. You can find all sorts of mutations. So there can be truncating mutations, non-truncating, this sense. In general, for PH type 3, the genotypes are a little less variable. That's shown down there on the bottom right. That 2 mutations in particular, at this point in time at least, accounted for about 70% of the PH3 mutations. And it's much more diverse for PH1 and PH2. As far as genotype and outcome, this G170R, which again is about a third of PH cases, if you're homozygous for that and you are pyridoxine responsive, you do tend to do better. So this again is showing renal survival versus age. And the red bar are the people that have 2 copies of this pyridoxine responsive mutation, perhaps because these patients are getting pyridoxine as part of this, but we also have noticed that their urine oxalate tends to be a little bit lower than the other type 1 PH patients, so I think that's another factor that favors that. If they're homozygous for other mutations that have been described to be mistargeting to the mitochondria, that may be a little bit protective. They do better, but it's not as if they're prevented from going on to renal failure, and it's not clear if this relates to not getting the pyridoxine early enough or compliance with it, but it is at least protective to some extent. Whereas if you have other mistargeting mutations, it doesn't seem to do quite as well. And then if you have no mistargeting mutation in blue there, those do the worst. So in this case, there is a certain genotype-phenotype correlation. And if we look out in the population as far as carrier frequencies, this is really getting at what we did here. This is work with Katarina Hopp and Peter Harris. Looked at all the known mutations for PH type 1 and then looked at the public databases and looked for the frequency mutations out there. And for PH type 1, we predict that the prevalence overall should be about 1 in 150,000, and this is consistent with other data that's out there. For PH2, maybe a little less, 1 in 300,000. But then for PH3, really seems like there's underdiagnosis of this because it should be as common as PH type 1, about 1 in 130,000. And there's not really any racial differences between European Americans versus African Americans, except for PH3 seems to be a good bit rarer in African Americans today. And that may have to do with the fact that there are some specific mutations that we see that account for quite a bit of the PH3 population. Well, one of the things that we observe in primary hyperoxaluria is that kidney function can really go from pretty normal to end stage quite quickly. And this has been, it's something if you see these sort of patients, you appreciate empirically, but we've been trying to do a little more quantitative assessment of this, in particular to understand how one might look at loss of kidney function in a clinical study and slope of kidney function and how that might or might not work for this disease. And what I was showing in this analysis, we took all the patients and looked at them by the first date that they entered a given chronic kidney disease stage. So CKD2 is when you get to below 75, CKD3A 60, CKD3B eGFR less than 30, and then 4 is, or this 3B is less than 45, and then this is less than 30 CKD4. And you can see even in the CKD2s that the patients start out at pretty good GFRs, all of them, because that's by definition how this graph started off on the left. But there are a lot of patients that just kind of fall off at some point, that they go from pretty good GFRs down to 0 and presumably started on dialysis. And as we go through these stages, you see that people drop off much earlier in general than not. And once you get to CKD4, so when they're less than 30, typically it's pretty quick when they go on to end-stage kidney failure. The quantitative way we've looked at it is the actual loss of GFR slope in these different CKD stages, and its overall median, at least, is fairly low in the CKD2 group, and it's similar in the 3A group, but then when we get to 3B, the slope is suddenly -4 per year, and then in this 4, it's -10 per year. So this is absolute. The percentages are even a little more dramatic. So it does really suggest that using slope of GFR in clinical studies for PH is probably going to be more complicated than for some of the other forms of chronic kidney disease where that has actually worked pretty well. once we get down to especially the 3B, that these are the people that are likely to progress pretty quickly, and you really do need to follow them pretty closely at that point, and be thinking about alternative therapies or if they're going to need transplantation or those sort of considerations. Well, the key parameter again is nephrocalcinosis. It's a specific kind. It's different than what you might see in like calcium phosphate stone formers or renal tubular acidosis. It's a corticomedullary nephrocalcinosis, and if you do a kidney biopsy, you're going to see calcium oxalate crystals in the kidney tissue itself. And why might that be? Well, this is work and presenting work based on Elaine Worcester and Fred Coe at the University of Chicago. And the idea here is that oxalate is freely filtered in the glomerulus, and then some can be secreted in the proximal tubule as well. But really, it's thought that nothing really happens to oxalate in the kidney after that part of the kidney, that through the thin limb, thick limb collecting duct, that there's no net secretion or reabsorption of oxalate. So if you take the urinary oxalate excretion, and then if you know how much fluid's been removed between this point and the end of the kidney, you can predict what the concentration of oxalate should be at the end of S3 of the proximal tubule. And it is known, there are estimates, and it's typically 0.6 to 0.7 is this R value, so that about 30% of the water's been removed by the end of the proximal tubule. So you can do this calculation and predict then, we know what the calcium should be as well. Calcium is pretty constant between people, and so we can know what the ultrafiltrable calcium should be, and do the calculations and sort of predict what the relative saturation of calcium oxalate would be at that part of the kidney. And you do this sort of exercise in patients with PH type 1, and it turns out that most, not all, are oversaturated at this part of the kidney, whereas in normal individuals, this is data from our clinic looking at various kinds of patients and controls, almost never do you see oversaturation at this part of the kidney. PH type 2, they often are oversaturated. PH 3 to some extent, but not as much as the other two. Gastric bypass, which is one of the common causes of enteric hyperoxaluria, a few patients cross that threshold, but in general not. And then your regular kidney stone patients, the vast majority would not do that as well. So really that's the thought of why you get nephrocalcinosis at this part of the kidney, that really it's this oversaturation. The other point here is that this number is also going to be very much influenced by what your GFR is. And the easy way to think about this is as your GFR goes down, you have less nephrons, and that same amount of oxalate's being excreted through fewer nephrons. And so this value tends to go up much faster as GFR goes down. And that's probably explaining our observation that when you get to this critical level of GFR that you tend to spiral down, because the urine oxalate excretion is going to stay high throughout. The liver is going to keep producing it at a certain rate, and that's going to lead to problems as you get below these critical levels of CKD. Plasma oxalate, I mentioned, is a very nice biomarker for us in this particular disease. And this is some data, so just cross-sectional data looking at eGFR on the bottom here versus plasma oxalate. And in general, your plasma oxalate tends to run pretty normal, and this is all PH1 patients. Pretty normal across the spectrum here until GFR start to get below 60. And then there seems to be this abrupt upswing. And in these patients then with CKD stage 3A, 3B or lower, plasma oxalate suddenly becomes a very useful parameter. Number one, it's important therapeutically that as plasma oxalate gets over 20, we know your risk of oxalosis goes up. When you see somebody with an eGFR of 45 and a plasma oxalate of 15 or 20, that really is a significant observation and strongly suggests primary hyperoxaluria. And this is just showing that kind of interplay between estimated GFR or kidney function and plasma oxalate. This is cross-sectional data from the Mayo renal lab. And we have plasma oxalate is most commonly tested in these PH patients, which is shown in blue, but then we also do have a lot of enteric hyperoxaluria patients shown in yellow. And then regular stone patients, occasionally people will be screening for disease, checking plasma oxalate in that group. And in general, in the PH population, as we saw in that last graph, the plasma oxalate goes way up as your GFR goes down. It does the same thing in EH, but it's shifted over quite a bit and really never crosses this critical threshold of 20 for the most part in EH, but it does quite commonly in PH once they get below certain GFRs. And then in the stone patients, again, your plasma oxalate tends to go up, but not as dramatically as GFR goes down. And in regular patients without any pH that are on dialysis, you can see plasma oxalates of 10 to 20, and that doesn't necessarily mean there's anything going on. Probably explains why we don't see oxalosis in EH really at all, or in the regular population on dialysis, but we definitely do in primary hyperoxaluria. And then also interpreting plasma oxalate, really having a figure like this in mind is very helpful when we draw these and we're trying to say, yes, no, do we suspect pH? You really have to take into account what their eGFR is. So much like we've seen with urine oxalate, and given the fact that we know there is this interplay between plasma oxalate and urine oxalate, it's also a prognostic marker. So in stage 1, here we took our registry data, looked at pH patients, and divided plasma oxalate into quartiles, much like we did with the urine oxalate. And certainly when we get below CKD stage 2, if you're in the highest quartile of plasma oxalate, you are at higher risk of progression to end-stage kidney disease eventually, and for stage 3, and then especially stage 3B. So this is the group between 30 and 45. So plasma oxalate is a prognostic marker of a worse outcome down the road in this particular disease. And this is showing what happens to plasma oxalate on dialysis. So it's high, and again, the scale here, so this is the average here of this population. So these are patients that had been seen at Mayo, and we had values for their plasma oxalate multiple over time that they had started dialysis. And the mean here is right around 75 or so. So that's a very high number. These are pre-dialysis plasma oxalates. And at that level, likely this is depositing between each dialysis session out in the tissues. It's not as if it goes up higher over time, and that's probably, again, because this oxalate, when it gets above a certain threshold, you cross the supersaturation out in the body, and it's depositing in bones and vessels and all sorts of bad places over time. And that's another reason why we really don't want to keep these people on dialysis very long. They can develop oxalosis, and this is typically over a year. So patients with pH, often not recognized, dialyzed routine 3 times a week kind of way. It starts to deposit in various tissues, and this can include bone, vessels, muscle, nerves, retina, and skin. And shown here, this is an eye exam, and this patient had pretty bad oxalate deposits in the eyes, which are these little yellow dots out here away from the nerve. This was a younger patient that developed a pathologic fracture. Her bones actually are increased density, but more fragile. And then this is the skin finding. So it can look a lot like calciphylaxis, but if you do a biopsy of it, you will see these birefringent crystals. That is not what you would see in calciphylaxis. Calcium phosphate would not fluoresce like this. And we've tried to quantify this. When do people get these? And we've, again, divided into these 6 different systems. And on these graphs, no oxalosis is the lighter orange, and then the dark brown is with oxalosis. So before dialysis, some patients develop some oxalosis findings even before they're started on dialysis. But after a year, this starts to go up, and then after 2 years, and by 4 or 5 years, most patients, and the numbers here are lower because either they've gotten transplanted or they've died while on dialysis. So the total numbers are less, but the percentage that would have any system involved in oxalosis becomes almost entirely by the time you get out to 4 or 5 years. And this is just to give you a sense of what happens to oxalate on patients when they're on dialysis. And this is normalized because we were pooling data from a lot of patients and just trying to express this on one single graph. But the oxalate starts out at a high level, and it drops by at least 50% on average by the end of the first hour, and then continues to drop out to hour 2 and 3 and 4. And really at that point, you're not removing. Down here is shown the dialysate oxalate, and then it really, you start to have diminishing returns. If we stretch out the dialysis beyond 3 or 4 hours, you don't really get a lot more oxalate removed. But what does happen once you stop the dialysis, and if we continued measuring or kept the person there and looked, it's going to pop back up to almost the previous pre-dialysis number within 3 or 4 hours of the session. So that really the way to get more removal in these patients is to dialyze them more often rather than longer. And that's why we typically, based on their urine output and what their pre-dialysis oxalates will do, we'll start ramping up their dialysis to 4, 5, 6 times per week for the period of time that they need to stay on dialysis. But again, even doing that, they're going to get into trouble eventually. So that really, we want them to go on to get something more definitive. And to date, that's been a kidney liver transplant. And this slide here is showing a represented patient that did go on to kidney and liver transplantation. So the liver part is to replace the defective enzyme, and then the kidney to give them a functioning kidney. There have been different strategies with this. Some places would prefer to do the liver and then hopefully dialyze them a lot and get the oxalates down and then do the kidney. And I think the opinions are mixed about which way to do it, but I think most commonly now it's being done as a combined kidney and liver at the same time. But it's really important to make sure your patient is in good condition going into this. So we do tend to dialyze them quite aggressively and hope to have their pre-dialysis plasma oxalate level as low as possible. And this period right after the transplant is really the period of greatest risk. So in this particular individual, he was being dialyzed very aggressively. So his pre-dialysis plasma oxalates were actually pretty good here, only 20 to 25, which is really excellent for this particular patient group. And then he got his transplant here, but then had some allograft dysfunction in the kidney, and the plasma oxalate starts to go up. So we really monitor the plasma oxalates very closely on a daily basis and keep dialyzing them until we know that this plasma oxalate is less than 20 for sure, and we really want it less than 10 to not put that new kidney allograft at risk for loss. And really, again, how long you're going to have to do this depends on how much systemic oxalate deposition there is in a given patient, as well as how good their kidney allograft works. If there's primary graft dysfunction, it's going to be more problematic. It can really take a while, especially depending on how long they've been on dialysis and how much oxalate's out in the tissues for this to get mobilized. This guy, and again, his was not so bad, his plasma oxalates before, so it wasn't surprising that he came down pretty quickly. But when we've looked at our whole population here, this is urine oxalate over time after a kidney liver transplant. Many of these patients will take, and this is months, so really to come down to normal here, which is 0.45, sometimes takes 6 or 7 or 8 months before they'll normalize, and that's presumably while they're mobilizing all this oxalate out in the tissues. So what are our treatment strategies? Well, number one is high fluid intake to the extent we can keep their urine dilute and their nephron collecting duct fluid dilute. They're going to have less risk for calcium oxalate crystallization. So that's always been the mainstay of therapy for these patients. Crystallization inhibitors is the next strategy. So we've traditionally used neutral phosphorus, but potassium citrate also works similarly. In the PH1 patients that are responsive to pyridoxine, that's a key part of their regimen. And then if they do get kidney failure, they need intensive dialysis guided by their plasma oxalate levels, and then hopefully can go on, at least traditionally, the liver and kidney transplantation has been the definitive treatment. Fortunately, we do have some solutions actually not only on the horizon. There's one for type 1 that's out there now, and it's the Alnylam lumasiran siRNA strategy. And shown here on the right is it's basically blocking glycolate oxidase. So it's not directly intervening with the enzyme that's mutated here, AGXT, but it's blocking production of glyoxylate from glycolate, and then that in turn can no longer make oxalate. And so it's a sort of substrate inhibition, if you like. When people receive this siRNA, their glycolate levels will go up, and that's been observed in the studies, but there's no known toxicity to having high amounts of glycolate. In particular, it doesn't cause calcium glycolate kidney stones. And so there was a lot of basic science that have been done to suggest this might work for type 1 PH. And indeed, the studies looked and are very promising with this. This was their phase 2 study, just showing there was a fairly durable effect here, that patients in phase 2, they went on this for open label extension out to 12 months. And for the most part, their urine oxalate levels were normal or close to normal in the majority of those patients that were receiving this. It's administered as a subcutaneous injection. And for this, the way that Alnylam is doing it, it's every 3 months. So it's really not that often. So they get one of these every 3 months. It is targeted directly to the liver and is blocking GO production at the messenger RNA level. The double-blind. Their phase 3 study was completed late in 2019, and turned out that this was quite positive. That their key endpoint was drop in urinary oxalate, and was highly significant that it went down over the 6 months that patients were receiving this siRNA treatment. And there was, in this study, no serious events or adverse events. It was well tolerated. Injection site reactions was really the only common thing, and these were none serious. They were transient and resolved. And this has been FDA approved now in early December. So this is actually out there, and potential treatment, but it's again only for PH type 1. As you may recall from this slide with the hepatic pathways, glyoxylate transition to oxalate mediated by LDH is key in both type 1 and type 2. And we also think in type 3 that it's actually mediated by high glyoxylate because of this substrate inhibition with 4-hydroxyoxyglutarate. And so in theory, if you can block LDH, that should also reduce oxalate production, and it might actually work for all 3 types of primary hyperoxaluria. There is a specific liver enzyme, so it's an LDH isoform A that's in the liver and not in your other tissues. So if you can target this directly to the liver and block this isoform, you could potentially treat PH. The siRNA that has been developed by Dicerna targets this A form of LDH, and it's going only to the liver. So they have also shown some phase 1/2 data. This was at ASN again a year ago. They showed some similar data at the most recent ASN a month or 2 ago, showing that, and this is just in patients with type 1 and type 2 PH, that there is similar reduction if we go out over time, that urine oxalate seems to be normalizing in a high percentage of patients. They're dosing it a little differently. They're giving it every month as opposed to every 3 months subcutaneously. Their phase 3 studies for type 1 and type 2 PH are ongoing as we speak. Probably there's going to be some results from that in the next year or so. So I think that especially for our type 2 and type 3 patients, there may be some exciting news down the road for them as well for very novel therapies. So in conclusion, primary hyperoxaluria can be caused by autosomal recessive mutations to at least 3 different hepatic enzymes. Frequent kidney stones occur in all 3 types. Chronic renal failure is common in type 1. It's rare in type 3, but intermediate in type 2. PH patients are at high risk of oxalosis once chronic renal failure ensues. Thus, these patients require frequent dialysis and careful monitoring of their plasma oxalate levels until definitive treatment can occur. Traditional treatments for PH include hyperhydration, crystallization inhibitors such as citrate and neutral phosphorus. A subset of the type 1 PH patients will respond to pharmacologic doses of pyridoxine or vitamin B6, 5 to 10 milligrams per kilogram per day. One promising siRNA therapy that targets hepatic glycolate oxidase was recently approved by the FDA for type 1 PH, and additional therapies are under evaluation for other hepatic pathways that could potentially be beneficial for all forms of primary hyperoxaluria. Thanks so much. I really enjoyed being able to give this presentation, and I'll throw it back to you.
All right. Thank you, Dr. Lieske. That was really an outstanding presentation on primary hyperoxaluria. And also, just want to remind the attendees about the small interfering RNAs and the pharmacology behind it, which I think is quite fascinating. You know, this is really the next generation in how we will treat our patients, modifying gene expression, gene silencing, and all that. It's quite cool. In my opinion. So we'll have Dr. Lieske back during the panel discussion. A lot of these portions were pre-recorded because of the pandemic and also because of concern about the weather. December 19th in Rochester and New York could be quite challenging at times. So, and you will see that probably in the panel discussion as well. But these are pre-recorded portions during this presentation. But if you have any questions, please feel free to put them in the Q&A. We have our faculty members live ready to answer those questions. Before we get into the next section, just a couple more shout outs. We had Dr. Hayashi from Hawaii, but now my other shout out is going to be to my very good friend, Eileen Brophy, a dialysis nurse who taught me about dialysis and still continues to do so. She is right now in Dominican Republic and watching this event. So Eileen, thank you so much for joining us, and thank you for all that you do as a nurse, providing the best care. I know my other nurse, and who's actually a nurse practitioner as well, Linda Takworian, also is on the program, and just want to thank them and all our nursing staff for taking such care of our patients in such tough times. So thank you very much. My other good friend is Dr. Kazmi, and he's on board as well. He has been a great partner of the Core Kidney Program, and I want to thank him for attending as well the session. A lot of you did attend or went to the exhibit booths during the break. Please do so during the next break. The instructions, should be in the chat box. It's quite simple. You just have to get out the Zoom and then you can get back in, but then you have to go back to the next. So just ask in the chat box or Q&A section, actually, if you have any questions. Our next break is going to be coming after our next presentation. And then also post-event, we'll have a 15-minute session in which you can visit different booths. Now, as I said, we're going to put Dr. Goldfarb to a lot of work. And our next section is from Dr. Goldfarb. And the topic is medical management of kidney stones. And this will be followed by Dr. Pearle, and she'll be going over the surgical management of kidney stones. Now, keep in mind, both Dr. Goldfarb and actually Dr. Pearle and Dr. Goldfarb were the lead authors on the guidelines, the AUA guidelines for management of kidney stones. And the link or the citation was put in the chat box. So please do go to the and get that article. So with that, Dr. Goldfarb, you're back on.
Thank you, Dr. Rastogi. I'm now going to talk about medical management of kidney stones in a general way, calcium and uric acid stones in particular. Well, I've talked about preventing kidney stones in the population, most people with calcium stones, and we can call that non-specific. And non-specific means without reference to a 24-hour urine collection. Everybody needs to have an increased urine volume, and I could make this slide a 1-hour talk, a 2-hour talk. I could talk about how to increase urine volume for a long time. And I think it's important that we think that that everybody knows this, every patient knows it, but we've really got to emphasize that this is an important therapy. It's supported by a randomized controlled trial. Actually, there is a couple that are suggestive of benefit. So there's no question that this is the most important thing you can do to prevent kidney stones. So back in the old days, 2014, I would write a prescription like this for water. My point was that this is a powerful drug. I have to write you a prescription. It's something that everyone understands. It's cheap. It's effective. It's safe. It's legal. The problem now is with using our electronic medical record, I can't get this, dramatic font. I used to take out my marker and say, I'm going to give you the really powerful treatment. One of my patients made this slide for me. This is what her desk looks like when she's at work. And you can see that this meter dose urine volume inducer, she would know that she has to get to at 9 a.m. to get down to this level at 10, at 11, and then noon. And she'd have another bottle for the afternoon marked with the afternoon work hours. So the point here was that this was a way of keeping track of this. The PUSH study that is being done by the NIDDK now is a study that is trying to find ways of getting people to increase their fluid intake. You don't need a monoclonal antibody to prevent kidney stones if you increase your fluid intake. You really have to talk to your patients about this as a serious topic and not make it a throwaway casual issue that gets no attention. So what about diet? We'll talk a little bit about that in more detail, but let me point out that calcium restriction has not been prevalent as a treatment for calcium stones since about 2002. It was never proven to reduce stone recurrence. It is associated with bone demineralization. And instead, and I'll show you the basis for this, we encourage patients to have 800 milligrams per day. There's about 250 to 300 milligrams in an 8-ounce glass of milk, 8 ounces of yogurt, 8 ounces of orange juice with calcium. So you need at least 3 servings per day, about that. And the beginning of this story goes back to Gary Curhan again. In Gary's first New England Journal paper in 1993, he divided people up, and I told you that this was the health professional follow-up study, only men in this study, divided them up into 5 quintiles based on how much calcium they ate, from the lowest to the highest calcium intake. And again, large prospective studies demonstrated that over the course of years, the patients who ate the most calcium had the decreased risk of stones. So as you go from lower calcium intake to higher calcium intake, almost a 50% reduction compared to the baseline risk of stones going forward. The people who ate the most calcium had the fewest kidney stones. Gary then showed the same thing in the nurses' health studies in women. The first paper on that topic was in the Annals of Internal Medicine in 1997. This really changed the world because it suggested that calcium restriction for calcium stones was inappropriate. Based on those epidemiologic or observational studies, Borghi did this study, and this is the diet that I give my patients. And that's why I say that calcium restriction went out in 2002. Borghi took 60 men in each arm with urine calcium greater than 300 milligrams per day. I don't want to call that hypercalciuria, but that certainly is what he called it in that paper. He put those patients in one of 2 diets, either what they called a normal calcium diet, 30 millimoles per day. That's 30 times 40 is 1,200 milligrams per day, about 4 servings of dairy per day. Reduce their animal protein, reduce their salt intake, and he compared those patients to a group that was put on a traditional low calcium diet, their calcium restricted diet that was prevalent at that time. 10 millimoles times 40 is 400 milligrams per day. Both groups were treated with low dietary oxalate, and they looked to see if the patients developed kidney stone over the course of the subsequent 5 years. It's a small study, but it's an important study. So here's the graph demonstrating that over the course of 5 years on the x-axis, the patients who ate less calcium, the low calcium restricted diet, also restricted for oxalate, had twice as many stones at the end of 5 years as the patients who were put on a low sodium, low animal protein, low oxalate diet, but they had more calcium intake, up to 1,200 milligrams per day. So this was really a powerful study. And I'll just point out here that the deficiencies here are that this study was small. It was done only in men. It was done in Italy. Is it something that you could do in the United States? Can you get people to be on low sodium and protein diets like they could with this Italian population? We're not sure, and we have not reproduced this study anytime recently. From the pharmacologic therapy point of view for calcium stones, I want to say something about thiazides, and I want to talk about potassium citrate. And when I say thiazides, I'm not talking about hydrochlorothiazide. I'll talk about chlorthalidone and indapamide. Here's a summary of 3 studies using chlorothiazide, chlorthalidone, and indapamide. And you can basically see that over the course of 3 years, the patients treated with drug in black had a significantly lower rate of stone relapse on the y-axis as compared to the control groups. Whatever thiazide was used, it was effective in helping prevent recurrent kidney stones. This is basically because thiazides reduce urine calcium. And, you know, again, I try to not say hypercalciuria. If you didn't have hypercalciuria and I didn't know what else to do for you, I could reduce your urine calcium by giving you a thiazide. This effect is thought to be mediated through proximal tubular effect. I make you a little bit volume contracted, increase renin and angiotensin. Angiotensin increases sodium reabsorption in the proximal tubule and leads to a reduction in urine calcium there at the proximal tubule. So urine calcium goes down and kidney stones are prevented. Chlorthalidone or indapamide, either is my choice. I tend to use indapamide for people who are normotensive. I use chlorthalidone for people with higher blood pressure, but indapamide does lower blood pressure, and that can be a side effect. Hypotension, lightheadedness may be reported by some normotensive people. You want to lower salt intake because that will augment the effect of the drug to lower urinary calcium. It will also help prevent hypokalemia that's induced by thiazides. Most patients, I also give them potassium citrate, and that's because they're likely to become potassium depleted as the result of their thiazide therapy, especially if they're eating salt. Do not use triamterene, diazide, and maxide. I told you that triamterene is poorly soluble. If you need to do something besides give people potassium supplements, you can use amiloride or spironolactone, both of which are preferable to triamterene. If you give people potassium chloride, you will have a nice effect. You'll help maintain their potassium, and you'll actually help maintain their citrate excretion because potassium depletion is associated with a low urine citrate. So even giving potassium chloride to people taking thiazide will help maintain urinary citrate excretion. Now, we haven't talked about the fact that kidney stones are associated with osteoporosis. In this study from Lauderdale, you can see that men with osteoporosis were 70% more likely to have a wrist fracture and twice as likely to have vertebral fractures as well. These numbers were not statistically significant in women, maybe because women have another reason to have osteoporosis, but you can see that the confidence intervals cross one, but the tendency was to go in the same direction. So people with kidney stones have more low bone, with calcium stones, have lower bone density and are at risk for fracture rates. And so it's important to point out that thiazides lower urine calcium, and as I tell my patients, that calcium is going to go into your bones. When I give you thiazides to reduce risk of kidney stones, I'm also treating you for low bone density. I also very often measure bone density. I get a DEXA in many of my patients with high urine calcium. In this study, they show that continuous and long-term treatment, this is in patients treated for hypertension, were protective for the effect on fracture risk. So you can see over time, this is on the x-axis from time of treatment at 0 here, patients had significant reductions in the risk of fracture over the course of several years in this Danish registry. This is not a randomized trial, but you can basically see that the risk of fractures went down. So when I give people thiazides for kidney stones, I'm telling them I'm lowering your blood pressure and extending your life expectancy. I'm preventing kidney stones, of course. I'm also preventing osteoporosis and fractures, which, you know, particularly for postmenopausal women, may be a lethal event. What about treating patients who have a low urine volume but cannot increase their urine volume? There's two groups of patients. One, I told you about occupational kidney stones. So if you're an athlete, you may not, or somebody who goes to the OR, you may not be able to increase your urine volume. There are also patients who cannot drink more fluid because they have a normal effect of increasing fluid intake on thirst. What's supposed to happen when you drink more water, you get a little hypoosmolar, suppresses hypothalamic thirst impulse, and you're supposed to stop drinking. And so there are people who cannot drink more. My suggestion would be that these are people who are good candidates for taking potassium citrate supplements. That surgeon before going into the operating room, the ball player before going out on the field, that hot, sweaty baseball field, the teacher before class. Many teachers cannot get out of class, can't leave their class behind to go to the bathroom. Cab drivers, I mentioned briefly, steel workers working in a hot environment. And maybe everyone should take their potassium citrate at bedtime, particularly the old men like me with prostatic hypertrophy who don't want to get up all night. Women have these problems as well, nocturia. And so potassium citrate is an empiric therapy. It's one that's not based on necessarily having a low urine citrate. It's based on the idea that maybe you can't increase your fluid intake all day long. And there's a lot of patients like that. But if you have a low urine citrate, then potassium citrate is certainly appropriate. That's the group that I'd call selected therapy for patients who actually have that low urine citrate. Try to avoid sodium citrate, because that increased sodium will lead to an increase in calcium excretion. And you can use it when you don't know what else to do. So when a patient comes to me and they've already been treated with everything else, and someone has said your urine citrate is normal, that's what I call a non-selected case. I give those patients citrate anyway when I don't know what else to do. Here's the other interesting thing about citrate. Citrate is also a treatment for bone density. And that's because citrate is an anion. It's metabolized by the liver and essentially is consuming protons or producing bicarbonate. And because bone is a buffer for protons, people who eat more animal protein, taking in more acid, will have lower bone density. So here's a nice study by Rito Krapp, is one of the authors of this paper in Switzerland. He's a nephrologist. And they showed that in these postmenopausal women, given potassium citrate or placebo, in red, they had an increase in bone density compared to placebo in blue at the vertebral bone density, L2 to L4. And they had the same increase in bone density occurred at the femoral neck compared to placebo. So when you give people potassium citrate, you can tell them, I'm not only preventing kidney stones, I'm having a positive effect on bone density. The combination of thiazides and citrate will have an augmented effect, not quite as strong as the effect of bisphosphonates, but something relatively positive and associated with fewer fractures. I referred earlier to the AUA guidelines. Peggy Pearle and I were members of this guideline panel. And I just want to point out that there is an alternative, and that is something that I addressed in this paper called Empiric Therapy for Kidney Stones. This was in 2018 in urolithiasis, and it's a kind of a different approach. And it came to my mind that this was something worth considering as a result of lecturing in other countries. In Australia, in New Zealand, in China, in India, there's not availability of potassium citrate. Some places even don't have access to thiazides frequently. And I realized that even here on First Avenue in Manhattan, at the hospital, I told you that many patients don't get a 24-hour urine collection. So I was interested in suggesting that there's an empiric therapy for kidney stones. And what we put forth was the idea that perhaps you don't have to do a 24-hour urine collection in any places in the United States, around the world, and the like. First, I told you that weight gain and overweight is associated with kidney stones. And of course, it's difficult to get people to lose weight, but it's important to point out that it's part of the metabolic syndrome and a risk factor for calcium and uric acid stones. We try to get people to increase their fluid intake and talk to them about 3 liters per day, mostly water, but I don't really care what you drink, water, coffee, juice, beer, it's all pretty much the same. We talk to people about their diets, and particularly after we hear that their diets are what they are, perhaps high in calories, but less sodium. Everybody in the United States needs to eat less sodium, less animal protein. I'm not trying to get people to be vegetarian. I'm just saying eat it a little less often and eat a smaller portion. Less oxalate and more dairy, according to the Borghi diet. The DASH diet, you're all familiar with, the dietary approaches to stop hypertension. That's a study that has not been done for kidney stones. It's basically for lowering blood pressure, but that diet will also help prevent kidney stones. We know we haven't tested it, but we know that people with more DASH-like diets have fewer kidney stones. And then I would suggest that we could even treat patients empirically with citrate supplements, potassium citrate, potassium bicarbonate, depending on what's available and what their insurance pays for. People with high blood pressure and kidney stones, treat them with chlorthalidone and indapamide. And people with low bone density, it doesn't matter what their 24-hour urine collection looks like. You could give those patients a bisphosphonate like alendronate. So none of these therapies require that you must know what the 24-hour urine collection looks like. And if every urologist talked to people about this, or address these issues, even if the emergency room doctors that saw patients with renal colic talked about these issues, we'd do better and prevent more kidney stones. So lifestyle, water, it's intuitive, it's inexpensive, it's accessible, it's over the counter. You just have to talk about this as an important medication. Reducing sodium intake, increasing dairy intake, it will help prevent stones and improve bone density. And reducing animal protein intake prevents stones. I'll tell you, it prevents COVID too, and it prevents global warming. These are all potentially interesting issues. Thiazides reduce urine calcium. It worked in people with normal urine calcium. Now, I should have said that before when I talked about doing this empirically. You don't have to have a high urine calcium to get a benefit from thiazides, improving bone density and extending life expectancy. And of course, you know that these are the best drugs for hypertension in the elderly, systolic hypertension, and people who are overweight. Citrate, similarly, helps prevent calcium oxalate and phosphate stones, lowers urine calcium, and increases bone mineral density. What about high oxalate? Well, that's an important determinant of supersaturation for calcium oxalate, but no study of the effect of lowering urinary oxalate has yet been done to show that it prevents stone outcomes. Maybe more important than lowering oxalate intake is to go with the Borghi diet and increase dietary calcium intake, especially if you find who has a low calcium intake. And some of those patients with high oxalate should be screened for primary hyperoxaluria, as you've heard. Some of them just need to take some dairy. They may have thought inappropriately that drinking milk was bad for calcium stones, and you can tell them otherwise. What to do about patients who are lactose intolerant is a harder question. It really hasn't been studied. Usually I tell them to take some calcium citrate, because citrate's good for kidney stones. I tell them to take their calcium citrate with meals, because then the calcium will serve as an oxalate binder as well, but that actually has not been tested. So I think that's a hard group of patients to address. Elena is a company that is putting forth a molecule that's an oxalate decarboxylase. It will basically degrade oxalate the way oxalobacter does, and it's being studied now in enteric hyperoxaluria. People often ask about allopurinol. There's some controversy here. There's just this one good study. Bruce Ettinger did this in 1986 in the New England Journal. They took patients who had high uric acid excretion, but had normal calcium excretion. And that's an important point. We don't know if this study would have worked if the patients had high urine calcium. But over the course of 3 years, you can see that the patients with allopurinol had fewer kidney stones than the people in placebo. Number of kidney stones, recurrent people remaining free of stones on the y-axis here. Allopurinol was associated with fewer kidney stones than the placebo. This is the only study that demonstrated it. It's something that I will use extremely infrequently if I don't know what else to do. If the uric acid is high and the urine calcium is less than 250 milligrams per day. But it is not an important treatment for calcium stones or for uric acid stones. Let me just point out that from the point of view of the AUA guidelines, there were a number of, a total 27 guideline statements, 6 diet therapies, and 8 pharmacologic therapies. None of these are extremely positive findings. And so reading this manuscript, which Dr. Rastogi has posted on his website, I think is useful. But thinking about whether diet therapies are important or not, there are more actual more pharmacologic therapies looked at in the AUA guidelines than there are diet therapies. And that's one of the problems with the field right now. So the argument has been made that perhaps medications are easier than diet. And perhaps you have to talk to your patients. Are you going to change your diet? Will you be able to reduce your sodium intake? Can you eat less animal protein? Or maybe you should be taking potassium citrate. Urocit K is potassium citrate. Citric K is crystals that you dissolve in a glass of water or in dapamide. These are different ways of looking at it, and the argument has been made that perhaps people would rather take a pill than change their diet. My experience is that younger people are willing to think about changing their diets. I want to do this in the natural way. Older people say, I've tried, I can't change my diet, give me that pill, doc. Let's just talk briefly about uric acid stones. I showed you this slide before. low urine pH is the issue. You want to get uric acid from the insoluble form. You've got to increase the pH to make uric acid dissociate, give up its proton, and turn into the soluble form. So the treatment is to alkalinize the urine, and most of the time it's potassium citrate. Because sodium increases urine calcium excretion, but that's not such a big deal in uric acid stone formers. Sometimes I use sodium citrate and sodium bicarbonate. Remember, some of these patients are diabetic. They may have a little CKD. They may be taking ACE inhibitors and ARBs or spironolactone, and it may be therefore preferable to give them sodium citrate or sodium bicarbonate. I only use allopurinol if I can't get the urine pH up, and that's particularly common in patients who have bowel disease. So I might use allopurinol in patients with large uric acid stones, recurrent uric acid stones, or patients with bowel disease where alkalinizing the urine is not so easy. Briefly, just to mention a couple of other things that we haven't talked much about, cystinuria. You know, every nephrologist has one patient, maybe every urologist has two. Increase the pH of the urine, so citrate's appropriate here. When we treat stones, we're giving citrate to bind calcium. When we treat uric acid and cystine stones, we're using that citrate to increase the urine pH because that changes the solubility of cystine and uric acid. Increase the concentration of cystine by increasing urine volume, and many of my patients are drinking 5 or 6 liters per day. Decrease the amount of cystine in the urine is reduce their salt intake and their protein intake. Salt increases the amount of cystine in the urine for reasons that are not clear. Protein is where acid comes from, of course, from protons, and that's where methionine, the precursor of cystine, comes from as well. And then lastly, we want to change the cystine into the soluble cysteine, and you do that using cysteine-binding thiols. In particular, of course, we use Thiola or tiopronin or D-penicillamine. Struvite stones, I mentioned briefly. I showed you a struvite stone from a non-functioning kidney. This occurs when urease, the first enzyme ever isolated, that's a good trivia question, urease splits urea and makes it form ammonia, NH3. NH3 is a strong base, takes up a proton, and becomes ammonium, NH4+. Therefore, the urine pH is high because the protons have been buffered by ammonia. Almost any organism can make urease. The classic is Proteus. Klebsiella does this. Even staph has occasionally been reported to make urease, but not E. coli. When the urine pH is very high, ammonium, which is now present in high amounts, combines with magnesium and phosphate to form struvite. In addition, because you now have this high urine pH, the calcium in the urine will tend to bind to phosphate as well, usually forms a form of calcium phosphate called carbonate apatite, and that's often mixed in with the struvite. And that's why these stones are called triple phosphate stones. When you see those coffin lids in the urine, those are the so-called triple phosphate or struvite stones or struvite crystals. How do you treat these patients? This is for a urologist. You need great surgery. You need great endourology to get out every bit of infected stone. In the rare patient where they have a urologic issue, you might use the urease inhibitor, acetohydroxamic acid. It's only been available for a couple of years recently, and I've prescribed it at 250 milligrams twice a day, a low dose, which may be effective for patients where surgery cannot remove all of the infected material. So kidney stones are increasing in prevalence. I've told you about exposures and genetic influences that contributing to their high prevalence. They're associated with other comorbidities. They're certainly preventable, and you can definitely think about all of the dietary and pharmacologic therapies to talk to your patients about. They're more than cocktail party nephrology is really what I think. Fred Koh showed these data where he was able to demonstrate in his practice that if he did kidney stone prevention and all the stuff we've talked about today, the number of kidney stones per 1,000 patient years was significantly reduced. The number of urologic interventions was reduced. The number of hospitalizations was very dramatically reduced. And the number of dollars was reduced by about $3 million per 1,000 patient years. this works. This is something that every kidney stone patient deserves to have. There's my contact information again. So that's my talk on prevention of kidney stones. I hope you believe that they are preventable. And I hope you will be able to take some of the information you've learned today to your practice and help prevent kidney stones. I want to thank Dr. Rastogi again for his interest in preventing kidney stones. Thank you.
Thank you, Dr. Goldfarb. That was once again an outstanding presentation. Before we go into the break, just a couple of things. Please, after the break, when you come back, Dr. Pearle will be going over the surgical management of kidney stones. Please don't miss that section. And then we'll have a panel discussion that will try to answer as many questions as possible. Now, I know there are questions being asked. I think there was just a question from Dr. Hernandez as well in the Q&A. So please asking that, and we'll try to answer them. If we can't answer them during today's presentation, we will get back to you and make sure that you get an answer. Just a few more shout outs. I mentioned Dr. Hernandez. So Dr. Hernandez is from El Paso. He's a nephrologist and a dear friend of our kidney program, core kidney program. Another person who's at the front line, and I wish them the best. Also, one of our interns over there too, Rohit Singhal, is there. He was actually here getting trained at UCLA and is now in El Paso. So I just want to send our best wishes to them and thank them for all that they're doing, really at the front lines in El Paso. Also, I want to do a shout out to the Hannah sisters. I know Miriam is on, our sisters Sarah and Helen. They've been a big part of our core kidney program for a very long time. So with that, just once again, our sponsors and exhibitors, I want to thank them for supporting us. We have our the education grants from El Nilam and Natera, and also our exhibitors. We have AstraZeneca, Aurinia, Fresenius, Natera, and Nefcentric. So please do make every attempt to visit them. They're here on a weekend to provide more information. And we'll be back in 15 minutes, and then we'll go straight into our next section. Thank you very much, and I hope you enjoy your break.
Dr. Rastogi has been my daughter's nephrologist, and he's been in charge of the clinical trial that she was in. And we've gone to all of his educations. You know, he's had a lot of Sunday afternoons where he lectures, also the kidney fair, and in all of these settings, we've learned so much because of him about kidney disease, kidney transplant, so many things. Because of that, I had a lot of faith in UCLA, as well as the statistics I was able to look up and just their top-notch transplant hospital. So physically, everything went well. The surgery, I had Dr. Gritch for my surgeon. The surgery was fantastic. Everything happened just as the transplant coordinator had educated me that it would. And I was well taken care of at UCLA. The emotional part was it was beautiful meeting Maria and her family, my family meeting her family. Prior to that, I had thought about the recipient so much, but I knew my family, we loved Caitlin so much, we were just all like, yes, she's getting a kidney. She's getting a kidney voucher. And that peace of mind that she got with that gave us peace of mind. And so then here I meet this family. It's like, oh my gosh, I didn't just give to the recipient. That kidney also went to a family that's facing something now that Caitlin will likely face in her future. And we had an immediate bond. And I learned that Maria had been on the transplant list for 9 years, not feeling well. And since then, I just had a text from her and her daughter just recently, and she's doing so well, and her color is good, and she feels well, and she can go out walking, and she can do things she couldn't do. I feel like that kidney donation enhanced my life, and I felt it right away after. It's a feeling that has lingered. It's a feeling I really can't explain, and I've talked to other kidney donors who agree with me. They would do it again in a heartbeat. We wish we could grow a kidney every year and give them again, and I'm really grateful to be a core kidney ambassador with UCLA, and I'm happy to talk to anyone that has questions about kidney donation or the voucher program. Also, you know, kidney donation may not be for everyone. So if you want to explore it and talk to someone, I understand it's a completely personal decision, but it's one that you may consider. And thanks for letting me talk about the voucher program.
For me, PKD, my first, I guess, personal experience with it was when I was 11. I was diagnosed with ultrasound, and my parents took me in for testing just because we knew of the strong family history on my dad's side. So they just wanted to know if I had it or not. And at the time, being very young, I didn't really know too much about it, and I didn't really understand things. And especially since, at the time, I didn't have any physical effects at all. And even now, I'm 27 now, and I have very few physical effects from it, fortunately enough. But, other than my kidneys are large, and I have high blood pressure, which I'm on a medication for. But so the way I describe it is, it's more of a mental burden, at these early stages, because the way I describe it is, it's like having a countdown clock kind of in the back of your mind. Like you don't currently have any symptoms, you're not really seeing any of the physical effects, but you know that at some point in the future, you will experience these effects. And, for me at first, it was a little overwhelming, but the way I just deal with that is I've told myself, I found that just staying positive and taking matters into your own hands is a good way to deal with that. And one way that I took matters into my own hands, so to speak, is in 2014 when I was still in my undergrad in San Diego at the time. I wanted to participate in clinical trials. I wanted to get involved somehow in PKD research and whatever I could do to help. So I looked up clinical trials, and I just happened to find one that was run out of UCLA. And the PI just so happened to be Dr. Rastogi. So I started participating in the trial, and we found out pretty soon after that, actually. I was just going through family documents, and we found the certificate from my dad's transplant. And lo and behold, Dr. Rastogi had been the transplant physician for that particular transplant. So he had evaluated my mother to be a donor and also had overseen some parts of the surgery as well. So it's just a small world. It's funny how things work out.
Throughout my time at UCLA, I was a part of the Bruin Beans Health Club, which is an undergraduate organization headed by Dr. Rastogi. It is one of the most prestigious undergraduate clubs on campus and is geared towards students who are interested in all aspects of health and medicine. It gives undergraduates the chance to be involved in the medical field, which is an invaluable experience early on in our careers. Through my involvement with Bruin Beams, I was lucky enough to have had the opportunity to participate in clinical research, outreach events, and to be mentored by Dr. Rastogi and his colleagues. I learned leadership skills, which will undoubtedly help me in my future career as a clinician scientist. Without Bruin Beams, I would not be where I am today. I was involved in 2 research projects, a drug for the treatment of diabetic kidney disease and a study of living kidney donors. Being a part of these projects gave me hands-on clinical experience and taught me the importance of medical research. After graduating from UCLA in 2018, I accepted a scientific research position in a lab which specializes in the study of viruses. I currently do serology studies relating to Ebola and Marburg disease, and most recently have been involved in COVID-19 research. I've had the opportunity to travel to the Democratic Republic of Congo, the epicenter of the current Ebola virus outbreak, to work on these serology studies. The purpose of this research is in the pursuit of monoclonal antibody treatments for both Ebola and Marburg viruses, which are within the same virus family. With a greater than 80% fatality rate, monoclonal antibody treatments are the best hope for a patient infected with Ebola. We have been using these serology tests to screen Ebola survivors and healthcare workers in the Democratic Republic of Congo for these precious antibodies. Smack in the middle of our work, the coronavirus pandemic hit. However, because of my lab's expertise in virology, we were given a large grant from the Gates Foundation to research monoclonal antibody treatments for severe COVID-19. We are working 24/7 in the hope of finding one of these treatments as soon as possible. I'm thrilled to be a part of this work, and I want to thank Dr. Rastogi for the experience of being a part of Bruin Beans Health Club, because it has certainly helped me get to where I am today.
Hi everyone, my name is Ray Gashtaseth. I'm one of the nephrologists at UCLA, Santa Monica and Beverly Hills. I want to talk quickly regarding kidney stones. There are more than 1 million cases of kidney stone every year in the United States. Obviously, they are very painful, so it's good to know how we can prevent these. If you have a recurrent kidney stone, please do not forget to talk to a nephrologist. There are ways for each type of kidney stone, it's different, to prevent them. The main top 3 recommendations are increasing your fluid intake, decreasing your salt intake, and also decreasing your animal protein intake. But again, each case is different and each person is different, so talk to your doctor first before making any changes.
Very good. Welcome back, everyone. I hope you enjoyed your break and also were able to visit some of the booths. Now we're in the home stretch, and we have two sessions left. One is from Dr. Pearle, and she will be going over the surgical indications and management of kidney stones. As I mentioned, Dr. Pearle is a world authority on kidney stones, and she lead author in the AUA guidelines. We put in the link in the chat box. Please do get look at those guidelines. They are quite helpful. And if you have any questions, we'll be having the panel discussion, but also put in questions in the Q&A box. Before we get into that, just wanted to, there was a question about a kidney fair next year. I would like to address that. It's on March 14th. And the kidney fair that we had this year, Anita will be putting the link for that in the chat box as well. So please go do and look at it, and we will send you more information about the fair next year. Like I said, it's March 14th. From most likely from 11 a.m. to 1 p.m. But for now, it's Dr. Pearle. You're on. Thank you very much.
Thank you so much, Dr. Rastogi. I really appreciate that you invited me to participate in this symposium on kidney stones. It's really an honor for me to be here and to share the stage with my esteemed colleagues and friends, David Goldfarb and John Lieske. Over the last few hours, you've heard extensively and quite eloquently on the pathophysiology, genetics, and prevention of kidney stones. And what I'd like to focus on during my talk is how we actually manage patients who have stones. And to that end, I'm going to divide my talk into management of the acute symptomatic stone event, the dilemma of what to do with patients with asymptomatic, non-obstructing calyceal stones, and I'd like to share with you some of the current evidence on surgical management of kidney stones. So for any patient who presents with a presumably acutely passing stone, classic symptoms of renal colic can certainly suggest the diagnosis, but radiographic imaging is really the cornerstone of the diagnosis of cornerstone in the diagnosis of patients with an acute kidney stone. And there are a number of imaging modalities that can be used to diagnose kidney stones with varying sensitivity and specificity, but CT by far has the highest sensitivity and specificity for diagnosing stones, along with its wide availability, its fast acquisition time, and the ability to identify stones of all compositions has made it the imaging modality of choice in the evaluation of patients with acute flank pain and suspected ureteral calculi. Unfortunately, CT is associated with a significant amount of ionizing radiation, and for patients with recurrent kidney stones, the use of CT imaging over time can lead to substantial radiation exposure. And as a result, some investigators have turned back the hands of time to some degree and have recommended going back to ultrasound imaging as first-line management for patients with suspected ureteral stones. Smithman and colleagues performed a large, highly publicized, multi-center trial in which over nearly 3,000 patients with flank or abdominal pain and a suspected stone were randomized to either a point-of-care ultrasound, a radiologist-directed ultrasound, or a non-contrast CT scan, and patients were then followed for 180 days and detected at various time points to assess their outcomes. The primary outcome parameter in this study was a 30-day incidence of a high-risk diagnosis with a complication related to either a missed or delayed diagnosis, such as a ruptured abdominal aortic aneurysm or diverticulitis with abscess or sepsis. And a second primary outcome parameter is cumulative radiation exposure up to 180 days. So what they found is that overall, the incidence of a high-risk diagnosis associated with a complication was relatively low in all three groups, and there was no statistically significant difference between the three groups. In addition, radiation exposure, both overall and the radiation exposure just in the emergency department, not surprisingly, was significantly lower in the ultrasound groups compared to the CT group. They also found no significant difference in secondary outcome parameters between groups, including serious adverse events, 7-day visual analog pain scales, return to the emergency department, or hospitalizations. So these authors suggested that ultrasound should be the initial imaging modality of choice in patients with a suspected passing stone. However, using ultrasound as the initial imaging modality does potentially lose important information about stone size, stone location, and prognosis, at least until further evaluation, perhaps with further imaging studies. And in fact, these authors ultimately performed a second study and published a second study in which they looked at 143 patients who ultimately underwent a procedure for stones after that initial emergency department visit, and more than 3/4 of those patients underwent CT imaging before intervention. So what did we learn from this trial? Well, I think we learned that in recurrent stone formers with classic symptoms, ultrasound, at least along with a KUB, could constitute first-line imaging. And for those patients without a history of stones, or for those who present without classic symptoms, then a low-dose CT, that is a CT associated with reduced radiation exposure that preserves the sensitivity of a standard dose CT, can be used as first-line imaging. Now, after the diagnosis of a stone, the goal is really to relieve pain. And we know that narcotic analgesics are effective in relieving pain, but they are associated with side effects. And there's been certainly recent concern about the risk for abuse or addiction. On the other hand, NSAIDs are highly effective. They have few side effects, but it is important to watch for contraindications related to gastrointestinal bleeds or compromise of renal function. Pathan and colleagues performed a meta-analysis of 36 randomized trials comprising nearly 5,000 patients, comparing NSAIDs versus opioids in patients with renal colic. And they found a marginal benefit of NSAIDs over opioids for initial pain reduction, and furthermore found that NSAIDs were less likely to require rescue medication for recurrent pain, and the NSAID arm had fewer episodes of vomiting, suggesting that NSAIDs should constitute first-line analgesics in patients presenting with an acute stone event. Now, probably the most commonly recommended treatment for the management of a patient with an acutely passing stone is to push fluids. And there are actually 2 trials, randomized trials, that evaluated the benefit of a high versus normal fluid intake in reducing the need for surgery or pain. Both of these studies randomized patients to either receiving no fluids or minimal fluids versus 2 liters of fluids over a 4 or 6 hour period of time. Both studies showed that there was no significant difference in pain scores, need for surgical intervention, or spontaneous passage rates in the 2 groups, suggesting that there's no evidence to support the practice of forced fluids, and maintenance fluids, or at least resuscitation to euvolemia, should be sufficient in most cases. So the next question then is, when do we intervene, and who do we need to admit to the hospital? Well, no intervention is necessary if a stone is likely to pass, if the pain is well controlled, if there's minimal or mild obstruction, and if there's no associated signs of infection. On the other hand, intervention, or at least admission and observation, is warranted when the stone fails to or is unlikely to pass in a patient who's experiencing unremitting pain, unresponsive to pain medication, if a patient has high-grade or persistent obstruction, if there are signs of infection, or in patients who have an anatomically or functionally solitary kidney. One of the tenets in urologic surgery is that obstruction associated with infection mandates prompt surgical drainage of the collecting system. And there's actually some recent administrative data sets that actually support that tenet. Borofsky and colleagues used the nationwide inpatient sample and identified 1,712 patients with a diagnosis of ureteral calculi and either SIRS or septic shock. Among this group of patients, 90% survived their hospital admission, while 10 of them succumbed to death. When they stratified patients according to whether or not they underwent drainage or decompression of the collecting system versus no decompression, they found that 8.8% of the patients who underwent decompression ultimately expired, compared to 19.2% of patients who expired who did not undergo decompression, suggesting that mortality rates are higher when the kidney is not drained. More recently, Oja Shah's group used an updated nationwide inpatient sample and identified over 311,000 adult patients with a diagnosis of urinary tract infection and renal ureteral calculi with hydronephrosis, and performed multivariable logistic regression analysis to identify predictors of death. They found that after controlling for patient demographics, comorbidity, and severity of disease, delayed decompression, that is decompression that took place more than 2 days after admission, was associated with a 29% higher mortality rate compared to early decompression after admission, again, suggesting that prompt decompression of the collecting system is mandatory. There are remaining questions in considering patients with obstruction and signs of infection. How do we identify those who need to undergo draining? In other words, what parameters and what threshold values of those parameters can predict infection? We can look at parameters like heart rate, white count, temperature, procalcitonin levels, or the urinalysis, but we don't know what cut points to use. And also, can we predict who will actually progress to septic shock after they undergo drainage of the collecting system? Now, for patients who have ureteral stones, we know that the more distal the stone is located in the ureter, the more likely the stone is to pass spontaneously. And we also know that spontaneous passage rates vary inversely with stone size. So that overall, about 50% of ureteral stones will pass spontaneously. But recently, there have been a number of trials that have suggested the ability of some drugs, primarily alpha blockers and perhaps calcium channel blockers, to promote the spontaneous stone passage of ureteral stones. And they're thought to act by either relaxing ureteral smooth muscle or producing a more coordinated contraction of the ureter to help promote passage of the stones. There are a large number of randomized trials that have compared medical expulsive therapy with placebo or no treatment control groups, and most of these trials have shown a benefit of therapy, but there have been a number of recent large high-profile trials that showed no benefit of therapy or showed a benefit of therapy only in certain subgroups of patients. Locke and colleagues performed a recent meta-analysis of 67 randomized trials comprising over 10,000 patients with 10 millimeter or less ureteral stones and comparing alpha blockers with a placebo or no treatment control group. Alpha blockers were associated with a higher stone clearance rate, a shorter time to stone expulsion, fewer hospitalizations, and less need for pain medication, although no significant difference in need for surgical intervention was found between the two groups. They also found greater efficacy in larger, that is greater than 5 millimeter stones compared to patients who had 5 millimeter or less stones. And although they found efficacy for patients with stones in the distal ureter, that didn't hold true for stones in the mid or proximal ureter. So is medical expulsive therapy beneficial? Well, probably, I think, at least for larger distal ureteral stones, but I think it is important to inform patients that this is an off-label use of the drug and that there is some conflicting evidence in the data. So in conclusion, for the first part of this talk, CT imaging is the imaging modality of choice for first-time stone formers with suspected ureteral calculi, but ultrasound and KUB can be used in select recurrent stone formers. NSAIDs constitute the best first-line analgesics in patients with an acute stone, and forced fluids are not recommended in this setting. Patients with obstructing stones and signs of infection should undergo prompt drainage of the collecting system. And finally, medical expulsive therapy is optional, but it may be advantageous, at least in patients with larger distal ureteral stones. Now, more controversial is how to manage the patient with an asymptomatic, non-obstructing calyceal stone. Treating patients avoids the morbidity of the acute stone event, but it may be that that stone will never become symptomatic. There are a number of studies that have looked at the natural history of asymptomatic renal calculi, and that's information we need to be able to properly counsel patients regarding management of their asymptomatic stone. And these studies vary according to the mean size of the stone, the follow-up, and the different parameters that are followed, the need for surgery, the symptomatic stone event, or spontaneous passage. One of the more recent studies, which is one of the larger studies with among the longer follow-up, is a study by Durad and colleagues in which they looked at 301 renal units and 238 patients, in which the cumulative stone size was 10.8 millimeters. At a mean follow-up of 63 months, they found that the majority of patients were able to remain on active surveillance. 59% of patients remained on surveillance, while 27% of patients required surgical intervention for progression of their stones or for the symptoms. 15% of them spontaneously passed their stone, and overall 39.5% of patients experienced a stone-related adverse event. On multivariate analysis, they found that younger patients greater than 50 years of age and patients with stone growth greater than 1 millimeter per year were associated with an adverse event. But can we give our patients more information? Can we identify those patients who are more likely to fail conservative therapy? Well, unfortunately, there really is no uniformity of data, and analysis of the effect of stone size, stone location, and patient characteristics has been conflicting, and we haven't been able to come to any uniform consensus. So management of asymptomatic, non-obstructing stones is reasonable, but it should be a shared decision with the patient. Unfortunately, attempts to identify subgroups of patients at higher risk of failing observation have yielded conflicting results, and that makes individualized decision-making somewhat difficult. Now, for patients who need to undergo surgical or intervention for their stones, almost all stones can be managed in a minimally invasive or non-invasive fashion with either shockwave lithotripsy, ureteroscopy, or percutaneous nephrolithotomy. Unfortunately, over the last few decades, lithotripsy technology has been disappointingly stagnant, while at the same time there have been substantial advances in technology and technique that have expanded the role of endoscopy for the management of upper tract stones. And while the focus has been on ureteroscopy as sort of the treatment du jour, PCNL is really the procedure that's associated with the highest stone-free rates, but it also has the highest morbidity. Orden and colleagues used administrative data sets in the province of Ontario to perform a population-based cross-sectional time series analysis looking at trends in the distribution of surgical stone procedures over a 2-decade period of time. They found that shockwave lithotripsy significantly decreased in its proportion of surgical stone procedures, while the proportion of patients treated with ureteroscopy correspondingly increased, with a crossover occurring at around 2004. PCNL is the least utilized procedure, comprising only about 5 to 6% of procedures, and that has remained relatively stable over time. Through the years, we've had the benefit of learning the limitations of shockwave lithotripsy and being able to refine our indications for shockwave lithotripsy. We've learned that with increasing stone size, shockwave lithotripsy stone-free rates decrease, retreatment rates increase, the need for ancillary procedure increases, and complication rates increase. We also know that if we stratify stone-free rates according to stone location, the highest stone-free rates occur for stones located in the renal pelvis or ureteropelvic junction, followed by the upper pole, the mid pole, and by far the lowest stone-free rates occur in stones located in the lower pole of the kidney, likely because of the gravity-dependent location or pole calyces. James Langone was the first to recognize the limitation of shockwave lithotripsy for stones located in the lower pole of the kidney, and he convened a multi-center randomized trial comparing shockwave lithotripsy with percutaneous nephrolithotomy for isolated lower pole stones. The primary outcome parameter in this study was stone-free status determined by nephrotomograms. He found that when stone-free rates were stratified by stone location, you can see that the stone-free rates for PCNL, shown in pink, were uniformly high regardless of stone size. On the other hand, stone-free rates for shock lithotripsy were highly size dependent and were really acceptable only for stones less than a centimeter in size, where the stone-free rates were 63%. And those stone-free rates were dismal for stones between 1 and 2 centimeters in size and greater than 2 centimeters in size at 23 and 14%, suggesting that shockwave lithotripsy is really acceptable only for less than 1 centimeter lower pole stones. And for stones greater than a centimeter in size, PCNL is best. So the indications for shockwave lithotripsy for renal calculi would be less than 2 centimeter non-lower pole renal calculi, less than 1 centimeter lower pole renal calculi, and stones that are not shockwave resistant. So cystine stones are shockwave resistant and shouldn't be treated with shockwaves. And even calcium oxalate monohydrate and brushite are associated with poorer outcomes with shockwave lithotripsy, although unfortunately we often don't have the benefit of knowing a stone analysis prior to treatment. Now, on the other hand, ureteroscopy can be used for nearly all ureteral stones, and it can be used for moderate-sized renal calculi. The AUA Surgical Management of Kidney Stones guidelines compared shockwave lithotripsy and ureteroscopy for the treatment of ureteral stones and stratified stone-free rates according to stone size and stone location. They found that overall shockwave lithotripsy had the least morbidity and the lowest complication rate, but ureteroscopy had the highest stone-free rate in a single procedure. That's data that's also been validated by Bowen and colleagues in a recent population-based comparison of retreatment rates, comparing shockwave lithotripsy and ureteroscopy using an all-payer claims database from South Carolina. Among over 136,000 shockwave lithotripsy and ureteroscopy procedures, shockwave lithotripsy constituted 60% of procedures, and overall 10.4%, there was a 10.4% probability of undergoing a retreatment. Among the 40% of patients who were treated ureteroscopically, there was a 7.5% probability of retreatment. So that overall shockwave lithotripsy was associated with a 20% higher risk of retreatment compared with ureteroscopy. But ureteroscopy really isn't the panacea surgical procedure that many think it is. In fact, only recently have investigators begun to subject ureteroscopy to the scrutiny of CT imaging in determining stone-free rates. And we followed in the heels of several others who performed retrospective analyses and one prospective analysis evaluating ureteroscopy stone-free rates using CT imaging. We prospectively evaluated 167 patients with 209 renal units with renal ureteral calculi treated ureteroscopically. All patients underwent CT imaging pre and at 6 to 8 weeks postoperatively, and we made every effort during the procedure to actively manually retrieve all fragments left in the kidney. Our median aggregate stone size was 13 millimeters. Our mean operative time was 82 minutes. And we quantified the number of passes up and down the ureter to retrieve stone fragments, sort of as a surrogate for how meticulous we are in removing stone fragments. And our mean number of passes was 35.5, but you can see the range extended up to 240 passes, which is a long day at the office. We found that despite how careful we were at trying to remove all these fragments, our stone-free rate was disappointingly low at only 55%. We then stratified stone-free rates according to stone size and stone location to see if we could identify subgroups of patients who might be more successfully treated ureteroscopically. We found that stone-free rates in the ureter were reasonably good at 82%, but in the kidney, those stone-free rates were only 48%. It was really a coin toss if those patients were treated successfully. For stones less than a centimeter in size, that increased marginally to 62%, but for stones between 1 and 2 centimeters, the stone-free rates are fairly dismal at 39%. So patients really need to be selected for whom a stone-free state is achievable. But why is it that stone-free is so important? In other words, what are the long-term consequences of residual fragments? Well, we can look at the shockwave lithotripsy literature to answer that question. And there are 5 trials in which they looked at the natural history of patients left with small residual fragments after shockwave lithotripsy. There were 640 patients in these trials, and a mean follow-up of 34 months. 40% of patients developed a symptomatic event because of their residual fragment, and of those patients, 57% ultimately required surgical intervention. Rob Nadler also looked at the natural history of residual fragments after ureteroscopy and identified 46 patients left with 4 millimeter or less residual fragments after ureteroscopy. And they found that 19.6% of patients or renal units, that's nearly 1 in 5 patients, experienced a stone-related event at a mean of 1.6 years. And that includes 2/3 of patients who underwent repeat ureteroscopy and 1/3 of patients who required hospitalization for renal colic. Ryan Steinberg, when he was a fellow with us, also looked at the fate of residual fragments after ureteroscopy, looking at our prospective database of 226 renal units treated ureteroscopically who were imaged postoperatively with a CT. We identified 155 renal units in 130 patients who had at least 1 year of radiographic follow-up, and we compared the outcomes of the 88 patients left with residual fragments to the 67 patients who were rendered stone-free. Our primary outcome parameter was a stone-related event. So we found that a stone-related event occurred in almost half of the patients left with residual fragments versus only 15% of patients in the stone-free group. We also found that the median time to a stone event was 20 months in the residual fragment group, and it was twice as long, 42 months, in the patients in the stone-free group. We found by Kaplan-Meier analysis that the 24-month event-free survival was 70% in the renal units who were left with residual fragments versus 98% in the renal units who were left without residual fragments or rendered stone-free. So residual fragments, even small ones, have consequences. So if ureteroscopy yields unacceptably low stone-free rates for larger stones, should we lower the threshold for PCNL? We know that the outcomes with PCNL are excellent. In this study from John Densett's group and Hassan Razvi's group in London, Ontario, over 2,300 PCNLs were analyzed, including 1/3 of patients who had partial or complete staghorn calculi. The overall stone-free rate was quite respectable at 81.6%, increased to almost 91% with the use of second-look fluoroscopy. And the overall transfusion rate was only 1.4%, with a major complication rate of 2.3%. This is really the gold standard. Unfortunately, there's a reluctance on the part of practitioners to utilize PCNL because of its higher morbidity, and that has led a number of investigators to progressively decrease the size of the nephrostomy tract and to introduce the so-called mini PCNL. So why mini PCNL? What the thought is if you reduce the size of the tract, you'll cause less damage of the kidney, resulting in less bleeding, less pain, and a shorter length of stay. The trade-off, of course, is that you can't remove large fragments or aspirate small fragments through a small tract, and it obviously takes a longer time to remove those fragments. Zhu and colleagues performed a meta-analysis of randomized trials comparing mini PCNL with standard PCNL and found that overall there was no significant difference in stone-free rates between the two groups. But mini PCNL was associated with a less drop in hemoglobin, overall fewer transfusions, a length of stay that was shorter, and lower visual analog pain scales compared to standard PCNL, and only operative time was shorter and favored standard PCNL. So mini PCNL preserves the stone-free rates of standard PCNL while reducing the morbidity. So maybe reduced tract PCNL procedures can compete with ureteroscopy for the treatment of medium-sized stones, where ureteroscopy has been shown to not be that effective. Regardless of the procedure, though, stone-free has to be the goal, and anything less really sells our patients short. So in summary, nearly all stones can be treated with minimally invasive procedures. Shockwave lithotripsy is best reserved for patients carefully selected by size, location, and composition. Ureteroscopy is effective for most ureteral and for small to moderate renal calculi. PCNL is reserved for large and/or complex stones, but the threshold size for PCNL is clearly decreasing. And finally, careful scrutiny of outcomes and honest reporting may ultimately change our treatment algorithms. Thank you so much, Dr. Rastogi. It's really an honor for me to be here and to participate in this symposium on kidney stones. And it's really a pleasure for me to join the virtual stage with my esteemed colleagues and friends, John Lieske and David Goldfarb.
All right. Thank you, Dr. Pearle. That was actually very, very good and outstanding. Thank you so much for that session. So with that, welcome back. We will now go straight to the panel discussion. So, and then we will reconvene after that. Thank you. So welcome everyone to our panel discussion. Once again, I'm extremely honored to have our panelists over here, Dr. Goldfarb, Dr. Pearle, and Dr. Lieske. In this session, we'll be going over, doing a bit more of a deeper dive into some of the things that we discussed earlier. And also, we compiled some frequently asked questions from our audience, as well as from our previous participants, and I'll be asking them to our panelists. So my first question is going to be for Dr. Pearle. So Dr. Pearle, one of the frequently asked questions, and also clinical need is, when can we send a patient with kidney stone home?
So if we're looking at a patient who's presents, for instance, in the emergency room, I think the first most important factor would be, is their pain adequately controlled? So oftentimes when patients come into the emergency room, it's because oral pain medications either weren't helping or they weren't able to keep them down. So patients have to be able to tolerate oral medications, and they need to have their pain adequately controlled with whatever pain medication they're sent home with. So that would be the first condition under which it's safe to send them home. And then secondly, it has to be medically safe. So in other words, their renal function needs to be relatively normal. They should not be showing any signs of infection, so that the obstruction of one kidney shouldn't be something that they should be sent home in a dangerous position. So as long as they don't satisfy any of those criteria for being high risk, then as long as they can have adequate pain control and take fluids, they should be able to go home.
Great. Then my next follow-up question would be, and if this is a patient that you would see in the ER and you said, let's observe them, how long would it be, Dr. Pearle, safe to observe the patient before you say, now we have to intervene?
So the answer to that question is a little bit difficult, but we base our information on actually relatively little science, and we generally say that it's safe to observe patients with obstructing stones for a period of 4 to 6 weeks. The fact is, it's very difficult to quantify the degree of obstruction, especially now when we do CT scans in the emergency room. The degree of obstruction doesn't necessarily correlate with the degree of hydronephrosis. So we don't really know how obstructed patients are. But as a general rule of thumb, our thought is that in a patient with partial obstruction, that it's safe to observe a stone for a period of 4 to 6 weeks, as long as their symptoms are well controlled and as long as their renal function is relatively preserved. So, and that's really based on data from dog studies in which they completely obstructed a kidney and then looked at how long it took to lose the function in the kidney. So we don't, that's really pretty soft data, but as a general rule, we would say 4 to 6 weeks if the pain is well controlled.
Very good. I was wondering if Dr. Lieske or Dr. Goldfarb have any comments or thoughts?
I agree with Peggy as usual.
Yeah.
All right.
I agree. Yeah, I've looked at that data, and it is based on animal studies.
Okay, great. Dr. Pearle, you brought an important point, a solitary kidney. And one of the things that we do to induce a solitary kidney is living kidney donation, right? We take a kidney. And I was the medical director recently for the Living Kidney Donor Program at UCLA, and we have quite a busy kidney donor program. And one of the challenges that always came up is when donors have kidney stones, right? And stone versus stones. And I was just wondering, what thoughts you have in clearing somebody with a kidney stone. And I would also ask the same question to Dr. Goldfarb and Dr. Lieske after that.
So I think that is a tricky question. In the past, I think that, and the nephrologist can correct me on that, but I think that was generally considered a contraindication for the safety of the donor. But I think that the guidelines have become much more lax in terms of allowing donors to have stones. But the concern for the donor is that once you have a solitary kidney, every stone is an emergency. You no longer have the luxury of observing a patient over a 4 to 6 week period of time if they're passing a stone. Every stone becomes an admission, it becomes an urgent intervention. So from that standpoint, there is certainly, I'd say, a pretty substantial implication for the donor in terms of losing a kidney if you have a history of stones, which is not to say that they're likely to end up on dialysis because they have stones if they only have a solitary kidney, but it just really, I'd say, amps up the urgency of every stone. So those patients would have to be managed, very aggressively medically for stone prevention.
Great. No, thank you. Thank you, Dr. Pearle. Dr. Goldfarb or Dr. Lieske?
Yeah. So, Anjay, we've written 2 papers on this topic in recent years. One was a survey that we did of transplant programs, which documented, as Peggy said, that the standards have gotten progressively more liberal. And that doesn't necessarily mean that it's safe. It is generally, the fact that the transplant programs want to do more kidneys. So, there's that kind of bias there. There isn't any really good longitudinal follow-up of kidney formers who become donors. The other paper that Vashish Tadapudi, one of the transplant nephrologists at NYU, and I wrote was just comparing all of the guidelines from different continents. The American guidelines are different than the UK guidelines and the EU guidelines. So there's definitely some heterogeneity in terms of what people think about this. Generally, I think that most people with limited numbers of stones are going to do okay. We could have an interesting discussion about whether or not you're more likely or less likely to have a stone in the remaining kidney after being a donor. If you think about it, if your urine output stayed the same, you've got twice as much urine coming from one kidney. But where exactly is that urine forming, in the collecting duct, as opposed to the thin limb, perhaps where stones are initiated? So I think that's an interesting question, but there's not a lot of longitudinal follow-up. John can tell you, though, that the Mayo Clinic has a lot of interesting data about the number of asymptomatic stones that are out there, and they've got more long-term follow-up.
Great, thank you. Thank you, Dr. Goldfarb. Dr. Lieske?
And so, I guess what I would say, I agree with everything that's been said. The bias has always been to be very careful with donors, that, we want them to be safe and we don't want anything to happen. So in general, the default has been if they have kidney stones because of the concern, theoretic at least, that there would be a problem, we don't accept them. But, over time that has laxed a little bit, and partly because usually the donors are very motivated to donate. A lot of these people, it's family members or friends, and they really do want to donate. And so it's pushed the boundaries a little bit. We have a protocol here, and typically kind of the cutoff is if they have one stone, we will do a metabolic workup, and depending on what we find there, potentially let them proceed. If they have more than one, we typically would not. But it's not based on a lot of data, like Dr. Goldfarb said. There are theoretical reasons that maybe it's really not that bad if it's someone that has a few stones over a long period of time. But I think a lot of people are very reticent to push that envelope for obvious reasons.
But
Yeah.
I might add too, though, that with the advent of CT and the increase in sensitivity of imaging, you find a whole lot of asymptomatic stones, as you just mentioned. And so the donor pool does shrink to some degree because of these asymptomatic stones. And, are you more likely to allow someone to be a donor if they have, multiple small stones, but have never had a symptomatic stone, versus someone who has had one symptomatic stone? I don't really know the answer to that, but we certainly pick up a lot of incidental stones on CT imaging now that's done for unrelated reasons.
Yeah, Dr. Pearle, and I think all the panelists, I mean, the concern is the donor pool, and we know that the wait list is getting longer and longer, and their family members or loved ones who want to help their loved ones, and we're pushing the envelope. We're pushing the envelope in age. I still remember we wouldn't take anybody, or we would be reluctant to take anybody over 65, and now we're taking much older. Same thing with blood pressure, one blood pressure medication stuff. So and now with the stone as well. And at the end, it's the risk versus benefit. I don't think there is a right answer, but education is going to be critical. I mean, and I think we'll come back to that in a lot more detail. If there is a donor who has a stone or passed a stone, is lifestyle modifications that they can do. So that was great. I think that's has always been on my mind about kidney stones and donors who have kidney stones. But Dr. Pearle, just to follow up, and this question is actually going to be directed to Dr. Goldfarb, but you have a patient who was in the ER or urgent care with a kidney stone, and we decided to discharge the person. And we'll come back to some of the procedures, the pros and cons. But so, Dr. Goldfarb, my question to you is about, so you have a patient who goes back to his primary care physician. The primary care physician calls you, Dr. Goldfarb, what do I do now? How much diagnostic workup? That's a first stone that has passed. What should we do?
Well, I think it's an important question because probably most people are not getting any evaluation at all. They hardly get any advice from the emergency room. They certainly go to their primary care doctors. And when I give talks like the talk that I've given for your group for this conference, Anjay, I very often say to the primary care people, you guys all take care of coronary artery disease, high blood pressure, atrial fibrillation, diabetes. Why don't you do something for kidney stones? It's really not that difficult and complicated. So if that first-time stone former just gets a set of, basic metabolic, look at their kidney function, their potassium, their bicarbonate, rule out renal tubular acidosis, make sure they don't have hypercalcemia, consider hyperparathyroidism, think about their history of bowel disease or some of the drugs that are associated with kidney stones, and then do one simple thing. Explain to that person that there's a dose of a very powerful medication. It's called water. You just need to increase your fluid intake to 96 ounces, about 3 liters a day. If you did that, you'd prevent, first, you'd make some interesting diagnoses in a few patients, but you'd also, in prescribing a powerful medication called water, you would prevent something like 80% of recurrent stones. And no one ever says that to many of the patients who are seen by their primary care doctors, who sort of think, okay, you had a kidney stone, end of story, that's it. Nothing has to happen. And of course, some of those people are going to have recurrent stones and get into a variety of other issues.
Right. So Dr. Goldfarb, I think you mentioned a very important point over here. So the primary care physician can do a lot of baseline testing, even with one kidney stone, just to make sure that and the chances of the recurrence of the stone. So that's great. I mean, and you mentioned some of the basic labs. When would you do a full metabolic workup, including a 24-hour urine collection for these patients?
So one of the topics in my talk was about empiric therapy without a 24-hour urine collection versus doing that metabolic evaluation. And the metabolic evaluation for recurrent stone formers is something that the AUA panel, the guidelines, which Peggy was the chair of and I was a vice chair of, is something that we recommend. But the reality is that that may be something that's applicable to the patients with bigger stones, more episodes of stones. Maybe if the primary care providers didn't think about that, if they weren't intimidated by the idea of doing a 24-hour urine collection and worrying about urine chemistry, worrying about renal physiology, that part of it, and simply thought about making some dietary changes and increasing fluid intake, maybe we would do very well. And then the 24-hour urine collection would be something that would be done by the urologist and the nephrologist with an interest in stones. And we're likely to see those people with more stones and recurrent stones, as we've talked about. So that evaluation, I think, comes later, after you've thought about increasing fluid intake, most importantly, and made some simple dietary manipulations.
Wonderful, Dr. Goldfarb. And that's interesting you say 3 liters. We have a very big PKD program or ADPKD program at UCLA, and I'm sure at some of your institutions as well. And I use the same language for them as well, that water is medicine for you. And ADPKD patients are also more prone to stones, which we'll be getting back into. But it's interesting you said 3 liters. I've heard 2, 2.5, but 3 is probably a good number. Dr. Lieske and Dr. Pearle, any more comments on this diagnostic workup? Initial diagnostic workup, at least.
Yeah. So initially, you're talking about the first time sort of stone former,
Right.
and I think that in general, it would always be better to have the urine. That it's always informative in a positive or a negative way if there's something metabolic there to be addressed, or if they just need to drink more fluid. So I think it would always be helpful, and it really comes down to sort of a cost-benefit kind of analysis. And the other interesting thing that Dr. Goldfarb was mentioning is that I do think that people other than nephrologists and urologists that are really into this get very intimidated by these numbers. It seems straightforward to people that do this, but other people, it's very intimidating. So there's a limited capacity for us to see these first-time stone formers. So I think in general, if it's an incidental kind of one event, that some sort of standard recommendations probably is the way to go for most people, unless they're terribly concerned. And then I think referring them is never a bad thing either.
Mm-hmm. Great. Dr. Pearle, any more comments?
Yeah, I agree completely with what's been said. I mean, I think the key is that you're just trying to identify the patients who are at high risk of recurrence. And those who aren't at high risk, you can give some general dietary measures, as David mentioned. And those who are at high risk, you want to go further with metabolic testing. And there's no reason that any primary care physician can't perform that screening evaluation. Just having recurrent stones is high risk. That's somebody who should undergo metabolic testing. But for first-time stone formers, you're really just looking at anything in their history, whether it's medication, dietary habits, or some medical condition that puts them at risk of recurrent stones. And it requires a pretty, just sort of basic knowledge to understand who comprises those who would be at high risk that you want to refer for further testing.
Yeah, thank you. That's perfect, Dr. Pearle and team. And once again, I think the summary would be that even the first-time stone formers, some basic testing and a detailed history can predict which are more likely to form kidney stones. And also Dr. Lieske mentioned, a bit more looking at the urine sample would also be helpful. The next question is about thiazides. And the question is it okay to prescribe thiazides and tell people to drink more water? Will you be worried about the risk of hyponatremia in these patients? And I'll ask Dr. Goldfarb that. I'll start off with Dr. Goldfarb.
Yeah, that's an interesting question. And that, of course, thiazides do increase the risk of hyponatremia. And somehow, and now I'm talking anecdotally because I don't have my own data on this topic, but I haven't seen hyponatremia in stone formers taking thiazides. Maybe that's not this is a particular problem in older people and more often in women than men. But I do have older women, and I do sometimes prescribe thiazides. Of course, I also like thiazides because when I give thiazides, I tell people it's going to increase your bone density, lower your blood pressure, of course, and increase your life expectancy. So I just haven't seen hyponatremia in an important way. But it's true that if it happens once, it's a bad thing. So usually I do get a set of electrolytes after prescribing any thiazide. I'm interested, of course, in the potassium and the uric acid and the sodium, but it's not something that happens often. And I think that we've written about this as well, and I don't think that there are good data on whether stone formers prescribed thiazides develop much in the way of hyponatremia.
Great, thank you. Thank you. Dr. Lieske or Dr. Pearle, any more further comments on that?
No, I think it's, it could happen. And certainly I do see older women when I'm in the hospital that have hyponatremia from thiazides. So definitely it happens. I think for stone prevention, we probably we probably filter that a little bit, whether we would or wouldn't prescribe it in those kind of patients. And then I think the other key is the follow-up. I mean, I always check the electrolytes in 4 to 6 weeks and, respond to that appropriately. But I have not seen any of my stone formers that I've given a thiazide.
Very good. Okay, great. The next question is about use of allopurinol for uric acid stones. Dr. Goldfarb, I'll start with you on that one too.
Okay.
That's okay.
What I know about uric acid stones, I learned from UT Southwestern. And that was very clear that the major risk factor is a low urine pH, and the treatment then is to alkalinize the urine, increase urine pH in order to prevent uric acid stones. Naeem Malouf's paper on this topic has a graph that everyone who talks about uric acid stones shows. What it shows is that if you lowered the amount of uric acid in the urine, but didn't correct the unduly acid urine pH, reducing the amount of uric acid is not going to prevent stones if the pH is not fixed. And there are certainly patients, particularly older patients with bowel disease and the like, who have uric acid stones without having a lot of uric acid in the urine. It's their urine pH that's the issue. So allopurinol, the only times that I prescribe allopurinol for stone formers, one, of course, with patients with gout, and gout is very often, like kidney stones, somewhat undertreated. So I do prescribe allopurinol in that instance. For uric acid stones, the patients with bowel disease may be difficult to alkalinize their urine, depending, their short bowel syndrome, diarrhea, and the like. And in those patients, sometimes I'll add allopurinol as a way of reducing the amount of uric acid. The key is to increase the urine pH.
Yeah, great. Thank you. I don't know if Dr. Lieske or Dr. Pearle has any more comments on that. If not,
no, I mean, I completely agree. It's such it's so often patients with uric acid stones are treated with allopurinol, and then their doctors are wondering why they're still making stones. And if you don't address the pH, it is unlikely you're going to prevent future stone formation. And as David said, even small amounts of uric acid will crystallize out and form uric acid stones if the pH is low. And conversely, even high amounts of uric acid, if the pH is high enough, will not form stones. So the urine will tolerate a lot of uric acid in it as long as the pH is above 6. So the key is the acidity of the urine, and that's the key to treating. That's the key to the pathophysiology and the key to treatment. and you're not going to get very far on allopurinol alone.
Great. I think that was quite important. My next question, we spoke about citrate, Dr. Goldfarb, a fair bit, or mention it at least. And one of the questions is do you hesitate to prescribe citrate supplementation to people because of the risk of calcium phosphate stones?
Yeah, so that's an important question. I sometimes claim that I have never given a talk about stones without getting asked that question. So it is a frequently asked question. The issue there, of course, is that citrate is effective as an inhibitor of calcium crystallization by binding to calcium in the urine. And so it will inhibit calcium phosphate stone formation. Of course, the other thing that happens with citrate is that it is metabolized and is potential base, and therefore will increase the urine pH. In essence, it turns into bicarbonate, will increase bicarbonaturia and increase urine pH. And at a higher pH, calcium will bind with phosphate, which turns from the monobasic phosphate to the dibasic phosphate. That divalent anion binds to the divalent cation. And so higher pH is considered a risk factor. And as I showed in my talk, John Lieske's paper on the number of stones occurring in the number of all the stones that were analyzed at the Mayo Clinic, there are more calcium phosphate stones in women in particular and younger women especially. So it's not an infrequent problem. Generally, based on a 24-hour urine collection, I would give citrate, and I think that the data generally shows that in renal tubular acidosis, a state with a higher pH, a higher urine pH, more calcium phosphate stones, that citrate supplementation is effective and prevents stones. If the calcium is on the high side, then of course using it concomitantly with a thiazide might reassure you that you are not going to promote calcium phosphate stones. And again, as from an anecdotal basis, I don't think that I have worsened people's stones. Maybe somebody turns from being a calcium oxalate to a calcium phosphate stone former. I believe that they will have fewer stones overall.
Yeah.
We need to do a randomized trial on this topic.
Agreed, 100%. Dr. Lieske or Dr. Pearle?
Yeah, I agree with what Dr. Goldfarb said. I think we don't have great prospective evidence, but I think the key there is to follow up the patients if you're talking about sort of a routine calcium stone former that has calcium phosphate stones, and see if you're helping or not based on the chemistries. I think is important. If it's a distal RTA patient, I do think we need to give those people citrate, that they need it for their sort of bone health in general. So that's a kind of a rare situation, but if you can prove that someone does have distal RTA, they probably should be on citrate, 1 mil equivalent per kilogram.
Dr. Pearle, anything else you would like to add, or?
No, I completely agree. I mean, you do sometimes find that the more potassium citrate you give, you may not be seeing a benefit in raising urinary citrate, and the pH may go up. But in that case, I might back off. But I think if you're getting the effect you want in the urinary citrate, then you're increasing inhibitory activity, and that's going to be beneficial in preventing recurrent stones.
All right, our next big topic is genetic causes of kidney stones. And I know Dr. Goldfarb went over this during his presentation. But we have some specific questions now. Number one, and we spoke about the diagnostic workup of kidney stones, and I think it was a very good discussion about the preliminary one-time stone former and what do we do, a detailed history, looking at the potential risk factors of kidney stones happening and identifying the risk factor and hopefully addressing it. I mean, I think that's probably the way medicine is practiced in any case, or should be. And then we also looked at the extended workup, which includes the 24-hour urine collection and all that stuff, metabolic, or even giving them the strainer to catch the stone. But my question, and Dr. Lieske, I'll probably start with you on this one, and have our other colleagues chime in. When would you go beyond the standard workup for kidney stones?
So when you say beyond the standard, you're talking about the genetic testing in particular, or?
Right, right. So,
Yeah.
so
So, I think there's one group, it's if they have hyperoxaluria, that's
Mhm.
going to be a high risk group, especially if you can't identify the reason, if they don't have a known enteric cause. And so I think the bar would be low to be looking for primary hyperoxaluria in that particular group of patients. And you find quite a few, I think. The other group is when it's basically the calcium type stone formers. And we've been doing a monogenic panel. So we have about 105 gene panel we've been running on various sorts of patients that we have suspicion of that they might have a genetic cause of their kidney stones. And it's turning out of those, about 20 to 25 are the ones that we're finding pretty often in those kind of patients. And the sort of the routine patients that's in kidney stone clinic is not really where we find them. It's more, I would say, younger patients, patients with chronic kidney disease, patients with strong family history, many stones, and nephrocalcinosis. Those are all, I think, tip-offs that you're going to find one of these calcium-related genes like CYP24A1 or one of the sodium phosphate reabsorbers, or there's the claudins. We're finding a fair number of those kind of genes. So I think the jury's still out a little bit, but I think genetics is going to play a role, especially in these tertiary stone clinics where we get these more recalcitrant stone formers. I think that we will find that there are a lot of patients with genetic causes.
Great. So 105 genes you test in these, and I think you gave a good. I mean, if the younger age, family history, recurrent stones, and also I think you mentioned nephrocalcinosis as well.
I would say especially nephrocalcinosis. I think pretty often we find something if they have true nephrocalcinosis.
Very good. Dr. Goldfarb, anything else you would like to add?
Yeah, I mentioned earlier that I had talked about doing empiric therapy, giving people water and changing their diets and not doing genetic testing. But as John said, primary hyperoxaluria is the best reason to do a 24-hour urine collection, because very often I think most of those people out there with primary hyperoxaluria are sometimes not diagnosed for a long time because they look like they're calcium oxalate stone formers. So they look like the rest of the population. So you have to have a particularly, be a low threshold for doing a 24-hour urine collection in patients, particularly who are younger, have more stones, and a decreased GFR, right? Those would be the sorts of patients where you really have to be suspicious, and getting a 24-hour urine collection really would be mandatory for those sorts of patients, to find that elevated oxalate and then screen them, right now that the panel that John's talking about, David Sass and John Lieske, in collaboration with Peter Harris at the Mayo Clinic, have a grant to do this for free. So we do, want to screen more patients and make sure we're finding the patients that he talked about.
I didn't know that. So it's a panel that we can, from UCLA, I can reach out to.
Yes, and it turns out, now we can do it with saliva. We can get the DNA, so that the kits are pretty, user friendly. They don't have to even go in and get their blood drawn right now. So yes,
we definitely would like to post that information at the end of this presentation, if that's okay with you, Dr. Lieske.
Yep.
So, Dr. Lieske, just continuing on the testing. When is liver biopsy indicated for primary hyperoxaluria diagnosis?
Yeah, so I think that's an interesting question. I think historically that's what we did. So you were looking for, actually, there were enzymatic tests you could do to look for the known decreased levels of the enzymes that can cause PH1 or PH2. And then they would also do, for one of the mistargeting mutations, you could, by electron microscopy, see where the enzyme was located in mitochondria or peroxisomes. And so I think it was very, very helpful in the pre-genetic testing era. But now that we can do very good genetic testing for the 3 genes we know that cause it, I don't think there is much of a role for that at this point in time. And we have not done one in, I would say, 10 years.
What if the suspicion is very high, but the test is negative? Would you consider doing a biopsy?
Again, I think that's a little grayer, and so I think you could think about it. I think that given the way we can do the genetic testing now,
it's pretty sensitive. And so I personally doubt you would find many cases, because they're only testing for pH1 and pH2 on those and the only place I'm aware of that does that is in London. So you have to send it over to University College London to get that done. And so we're looking at those genes very carefully when we do the genetic testing now. So I don't know, I guess we could talk with them if they've ever found one that was the genetic testing was negative and they found the enzyme was abnormal. I think more likely it's going to be that it's some other genetic cause if it really is a genetic case, and you're not going to see that on that because they're only looking for those two types.
Great. Dr. Pearle, any further thoughts on that or comments, or Dr. Goldfarb?
No.
Dr. Lieske, about liver transplantation. I mean, obviously that's a big. The next question is liver transplantation indicated for primary hyperoxaluria type 2 and 3?
Yeah, and so I think that's it's very evolving at this point. So I'll start at pH2. I think traditionally we had thought that that was really not indicated for type 2 pH for a couple reasons. One is the urine oxalate levels tend to be a little bit lower in pH2, and the risk of kidney failure in those patients is a little bit lower. So in general, they do somewhat better if you do just a kidney transplant as opposed to a combined kidney and liver. And there was also, it wasn't clear that the enzyme, the GRHPR, it is expressed in other places besides the liver. And so it wasn't really known if you did a liver, would that really cure them like it does for pH type 1? On the other hand, if you look at the data that it is available more closely, it seems like even though it is expressed in other tissues, it's expressed most highly and most active in the liver. Now there are at least several case studies. We did one here where we had a gentleman that had very high oxalates and had recurrent loss of grafts. And we did a liver kidney in him, and his oxalates went down to normal afterwards. And I know there are a couple other cases like that. So I think for pH2, that's a viable option in the right kind of patient. For pH3, in general, I don't think we know a lot about, would that cure a patient with pH3? And then the other issue there is that the rate of kidney failure is quite low. There are a few cases known in the literature, but their oxalate levels are even lower. And it seems like their risk of kidney failure, although it's not zero, is not substantial. And I think that the morbidity of a liver kidney transplant is pretty high, and it would take a lot to, I think, push most people to do that in that kind of a patient.
Great. Thank you.
The other thing that's, of course, influences these decisions is the availability now of small interfering RNA. And so I'm a site PI for Dicerna's study in New York, and that is a small interfering RNA. It's taken up by the liver, turns off LDH, which is one of the downstream enzymes forming oxalate. It appears to be safe, and it appears to be effective. So that would be an agent that would be effective for pH2 and pH3. And potentially, and the data are not quite there yet for those two disorders, but potentially that would make liver transplantation for pH2 unnecessary, potentially make kidney transplant, make it go away, make renal failure not happen. So that's something that's, I think, very exciting. I recently had a patient with pH2 who was one of the bad cases. He developed kidney failure. And the choice was, should we do a liver transplant? We were certainly influenced by the Mayo Clinic's experience doing that, but then thought perhaps he'll be able to get the Dicerna product with time, and we just did a kidney transplant and not a liver transplant. So sadly, for a variety of reasons, his kidney hasn't done that well. He's got a creatinine of 3.5 or so, which has nothing to do with that's just the usual transplant stuff. It hasn't gone so well, but ultimately we feel like we will get him into a Dicerna study and avoid doing, a big procedure like a liver transplant.
I agree with all of that. I think it's a very changing landscape with the new therapies. So I would hope that we won't be doing liver transplant at all in these patients, in a year or two, once these things become more established. I think that's probably where it's going. PH3 is kind of an interesting topic. They have not dosed any people with the Dicerna LDHA siRNA yet, but they will be in the next phase of their study. So I think that'll be an interesting, observation. Does it really reduce their oxalates? We think it will, but I think more to come on that.
Well, fascinating. And I want to come back to this novel therapy. My background is also pharmacology. And when you look at these small interfering RNAs and gene expression and gene silencing, so I do want to get back on that, but I'll just see if Dr. Pearle has any comments before we get more into small interfering RNA. Okay, so I think that was, we spoke about liver transplantation and also hopefully preventing kidney transplantation. We also discussed the donor pool, the limitations in donor pool, and and all the people on the panel today are from big academic programs that do a lot of transplantations, and we know how limited organs are. So let's go back to this small interfering RNA. And Dr. Lieske, I'll start with you on this, and maybe Dr. Goldfarb and Dr. Pearle. Can you just describe, just in very simple words, the mechanism? This is a very novel way of treating a disease.
Yep. So it is very novel. So it's they have a way of it goes and targets a specific messenger RNA for a specific protein, which the sequence for those is very specific. So as long as they can match up to that, it can knock down the translation of that into active protein. And I think the other key to the sauce is that they have ways to target these to the liver. So it's taken up largely in the liver. So whatever messenger RNA they're targeting, it'll only really have an effect in the liver itself. And so I think that this has been worked out over the last 5 or 10 years, the way to do this. And these companies are really looking for diseases where there is a gene in the liver that you can knock down that would be curative for that disease. And I think that's how primary hyperoxaluria came to their attention, that that's one of those specific diseases. And so they're targeting different enzymes. And it's not actually the specific enzyme that's deficient in pH 1 or 2, but it's things that are in the related pathways that can then decrease substrate or decrease production of oxalate related to what's overproduced because of either type 1 and type 2. So in one case, it's glycolate oxidase, and the other, it's LDH form A. And it so far, it can be dosed different ways. The two companies are actually taking different strategies. One is doing it every 3 months, the other every 1 month. And there's kind of pros and cons to doing it those ways. But from a patient point of view, it's really pretty straightforward and really seems to be well tolerated and very safe. So I guess more to come. The experience so far, even in the Alnylam studies, which is the longer that's been in the pipeline a little bit longer, we still only have about a year's worth of experience with those, but it does seem like it's working pretty well. So I think more to come, but it's very exciting.
And it just got FDA approval as well. So
yes, very early December. So yeah, it's FDA approved,
so
but
very, very timely.
Yes.
And I think, I think that's where, and when I asked, when do we go beyond? And like I said, once again, we are all from academic institutions, and we get these complex cases, or so I think we just have to keep in mind that these testings are available. And now you have that 105 genes panel at Mayo Clinic. That's good to know. But also there's a treatment, especially if we can, prevent liver transplantation and even kidney transplantation for that matter. Because, even if you get a kidney transplant, the disease is going to come back at some point.
Right.
So I think that will be a great benefit. Also, you mentioned, Dr. Lieske, about the safety. Can you discuss that a bit as well? Safety and tolerability of.
Yeah. So far, like for example, with the Alnylam, it increases glycolate production because that's the enzyme that's blocking glycolate oxidase. But there's no known ill effect of that in the patients that have been dosed to date, which I think it's probably around 100 or so, maybe. No ill effects have been noted from that. And in general, the only side effects have been injection site, kind of mild things, has really been the only reaction noted to date. So I think so far so good. There really doesn't seem to be a lot of ill effects from it.
That's awesome. And you know, we are working on different disease states with the same platform. You know, so that's good to know, because you know we're looking forward to that. You know, especially of these genetic diseases. So.
Yeah. But I think it's very important for us to find these patients. I mean, you know, it isn't an accident that these therapies are becoming available for PH, because there was a lot of work in that community identifying these patients and developing cohorts, knowing that oxalate was a key biomarker for that. Once this technology became available, then that really rose to the top of the list for these companies to apply it to. And I think there's a lot of other of these monogenic diseases that, you know, if we can identify these patients, learn more about their disease, how it's causing nephrocalcinosis or kidney failure or kidney stones, there will be similar technologies that'll be available pretty soon, I bet, in the next 10 years. But we really need to do the legwork, I think.
Mm-hmm. Yeah. Dr. Goldfarb, I had a question for you. This was some of my previous questions. You know, the link between kidney stones and you know, chronic kidney disease. Obviously, here with primary hyperoxaluria, that's a different story. But the link between kidney stones and chronic kidney disease, and also the link between kidney stones and osteoporosis and vascular calcification.
Yeah, these are both complex topics. The link between kidney stones and CKD is something that we've been interested in as the result of our work with the Rare Kidney Stone Consortium. John Lieske and Andrew Rule particularly have written important papers on that topic. Is it that people with kidney stones have had lots of procedures, lots of episodes of obstructive uropathy, or are there just common risk factors like vascular calcification that's associated with kidney stones and associated with obesity and diabetes and hypertension and some of the risk factors that we talked about earlier? So it's possible that these two things are going on together. John certainly has done work on oxalate as a mediator of inflammation, and that may also be important. People with hyperoxaluria certainly are at risk for nephrocalcinosis, obviously, but it could be that oxalate has a role in promoting chronic kidney disease. There's an important paper about a year ago from Sus Weicker at BU demonstrating that 24-hour oxalate correlated with decreased GFR. So the possibility that oxalate is a determinant of progressive kidney disease is real, and something that needs to, there are further studies going on about that topic. The other thing, of course, well described are the links between bone disease and kidney stones. And people think that there are two possibilities. You may have a bone problem releasing calcium. The kidney then is an innocent bystander. You get kidney stones. So those two things go together. Or the other possibility is that the kidney is losing calcium, claudin mutations and other factors related to calcium and vitamin D metabolism. And that loss of calcium in the urine then puts the patient into negative calcium balance and contributes to decreased bone density. And then there's all sorts of other possible links between kidneys, bone disease, and the like. So these are very interesting topics, and certainly lots of observational studies have demonstrated these links. But the direction of the causality in all of these disorders is not always clear.
Great. Thank you so much, Dr. Goldfarb. So, Dr. Pearle, this question is for you. If you can just discuss the current guidelines that are available for kidney stones.
So Dave and I were involved in the guideline on medical management of kidney stones that was put out by the American Urological Association in conjunction with the American Society of Nephrology and the Endourological Society. That was a joint guideline that was put out in 2014. But as is the process with AUA guidelines, they are reviewed every 2 years. to be sure that they remain current and the literature review is updated, any further analyses are completed, and then there's a determination made as to whether or not any of the guideline statements need to be changed, eliminated, or new guideline statements added. And that re-review was done in 2019, and we didn't find, unfortunately, that there was any substantial data, new data available that changed the outcome or the wording of any of our guidelines. So we did not make any substantive changes to our guidelines based on that. At some point, the guideline will sunset. I think it's at 10 years, the guideline sunsets, and any further guideline would have to be done all over again. The only other guideline available comes from American College of Physicians, and it's a guideline that's much less extensive. There's much less guidance, many fewer guideline statements. We had a total of 27 guideline statements in our guideline that some of which were based on expert opinion and general consensus, but there's value to that, and there are some things that aren't going to be studied in great detail, and yet it's felt that there are recommendations to be made based on generalized knowledge and expert opinion. So we feel strongly that the 27 guideline statements were important, some based on level 1 evidence, some not, but at least it does provide the practitioner with guidance. And I think if you read the guidelines, there's almost a cookbook approach to how to medically manage patients, certainly regarding who to evaluate, how to evaluate them, and then what recommendations should be made, both from a standpoint of dietary recommendations and the initiation of medical therapy. So the guidelines will need to be updated and will be done as new evidence is available.
Great, thank you so much. So Dr. Goldfarb, we can finally see you now. So it looks like the power is back on. So so one final question. Do you think nephrologists can do a better job in kidney stone prevention?
Yes. At a time where our workforce has had a difficult time, where nephrology has not been so popular, I've tried to suggest that doing kidney stones is something that enhances my life as a general nephrologist. I run a dialysis unit. I take care of lots of CKD patients. I do everything that most general nephrologists do, but I also have this interest in kidney stones. And that's something that I have promoted for the fellows that I train. And I've suggested to them, as I said before, go out there and tell the urologists that this is something you want to do. It's fun to take care of a younger group of people, a healthier group of people than we are often taken care of when we do dialysis and CKD. It's a group of patients with a lot of interesting disorders. We're making great progress in terms of new therapies as well, and genetic testing, as we've talked about today. And then it's a way of enhancing your knowledge of renal physiology, vitamin D, parathyroid hormone metabolism, what we call CKD, MBD. So for me, this is something that enhances nephrology. The idea that you might be a uronephrologist and hang out with the urologist and do this is something that I think makes nephrology fun and interesting and challenging.
Thank you, Dr. Goldfarb. I think just the way you spoke it, I'm interested in nephrology now. So thank you very much.
Great.
Dr. Lieske, anything?
No, I agree 100%. I think that, we think that a lot of this has to do with physiology, and, nephrologists understand renal physiology better than anyone else. And I think especially from a research and moving forward point of view, I think the more that we see these patients and generate questions and delve into things, I think that's the only way we're going to get further as far as treatments for kidney stone disease. And it's been a part of our fellowship program at Mayo for, decades. And I would say our fellows really like doing this. So I think it also draws more people to nephrology. So I think there's a win-win-win kind of thing.
Very good. Thank you.
One other comment. Remember that I'm a stone former myself. I mean, patients with kidney stones deserve this treatment, right? They're somewhat neglected. And there's a handful of people. 3 of us are here doing this, and now you're one of our group, Anjay. And there's just not a lot of people, nephrologists and urologists out there, who are putting forward an effort to take care of kidney stone patients and prevent stone recurrence. Partly, I think that's sometimes kidney stones are not taken very seriously. You have an episode, it's over, goes away. We know that there's a lot of suffering, there's a lot of misery, and that this is a really consequential disorder. It's associated with all of those metabolic risk factors, with decreased bone density, with hypertension, and even with increased rates of vascular disease like myocardial infarction. So I think the patients need this as well. And I really want to urge all the nephrologists who are listening to stay involved and do this kind of work.
Thank you so much, Dr. Goldfarb. That was excellent. And last but not the least, Dr. Pearle.
Yeah, I mean, I agree completely. I think the more the merrier in terms of practitioners who are taking care of kidney stone disease. I mean, as I mentioned earlier, the vast majority of patients can be managed, pretty simply, whether with diet or with medication. And it's only a small percentage of patients who really need to go on, to have more specialized care and more advanced providers. And it's a very common disorder. And I think I would say the same about urologists as you're saying about nephrologists is, so many urologists are intimidated by kidney stone management, and it's just not that difficult in most patients. It's understanding some basic pathophysiology and applying some fairly simple algorithms. And the patients have to be followed. If they're on medication, they have to have, follow up with blood work and x-rays and various other things to monitor them for side effects. But for the most part, it's no more complicated than any of the other things we do in urology. There are other medical conditions that we follow in urology as well. So I, encourage, I think getting, nurse practitioners or PAs involved is also good, because they can be very helpful and maybe have some more of the time for counseling. But I still always encourage my colleagues to get involved in medical management. It's really important for patients. We're really doing them a disservice if we allow them to have stone after stone and we treat them surgically and then we don't intervene medically. And it's leaving out a whole part of their medical care.
I mean, that's very powerful, Dr. Pearle. And I also like the idea that you mentioned about the NPs and PAs, and as an extension to the program. But I think this will be very inspirational for all our urologists who are actually listening to the program, prevention of kidney stones and getting involved with the medical management. I think this pretty much concludes our panel discussion. I do want to thank all 3 of you. It's been truly my honor and privilege to be a part of this panel discussion. So that concludes the panel discussion. I really hope you found that useful. There were a lot of questions that we didn't have time to answer, but we have all the questions. The panel discussion will be posted or will be on the website for 3 weeks, but that's after Corey sends you, or you get a notification from the CME office that they're posted. And once they're posted, you can have access to them for 3 weeks. So please do look at the panel discussion. There's an extended version of the panel discussion where a lot of the questions that are being asked will be answered. Also, if there are other questions that you have asked and we haven't answered, or you can think of, please feel free to email us, and we will have our expert panelists get back to you in a reasonable time. So please do feel free to. We really wanted to make it as interactive. I know in this pandemic age things are difficult, but we will get back to you. Also, for the mock points, maintenance of certification, the CME office will be sending you some questions. If you're interested in getting the mock points on top of the CME credits, please send those responses back, and we will give you the mock points for this. Also, if there are any feedbacks or comments about this event program, this was, like I said, was put together within 6 weeks. And looks like hamburgers are not the way to go because, I mean, I tried to promote that, Dr. Pearle, but looks like Dr. Goldfarb won over here. So citrate is the way to go. But besides that, if there are any feedbacks, any comments, please send us to us. We always take them, seriously, and we pay attention. In next year is going to be interesting for a lot of reasons. One is the anemia management. The HIF stabilizers are hopefully will be on the market, and we'll be doing another event on anemia management in general. We'll also be doing an event on SGLT2 inhibitors and their role in cardiac and renal protection. So stay with that. Our email address is plastered all over, so feel free to email us. I want to thank all our supporters. Once again, going one by one, I want to thank El Nilam for their educational grant. It's very much appreciated. I also want to thank Natera for the educational grant that they provided us to make this possible, and all our exhibitors, and that includes Aurinia, Fresenius, for the Velphoro products, Natera, Nefcentric, which is very, very important, and AstraZeneca. So we truly appreciate the support that has been provided. I also want to thank all my staff and teammates over here, the CME office, the core kidney program, everybody, and then all our faculty, our guest faculty. Like I said, you're truly rock stars, and thank you for participating in this, and all our faculty from within UCLA Health. Thank you for joining us on a weekend. So with that, we still have 15 minutes after the event is over. If you do want to visit some of the exhibits, please do so. They're here to answer any of your questions. But with that, we sign off from UCLA. I once again thank you. Please be safe, please be healthy, and have a very blessed holiday season. Thank you very much for attending our event.